Kedokteran, Kesehatan Masyarakat, dan Keperawatan Universitas Gadjah Mada Yogyakarta. Saat ini Anda berada di Auditorium Fakultas Kedokteran, Kesehatan Masyarakat, dan Keperawatan Universitas Gadjah Mada Yogyakarta. Berikut kami sampaikan safety briefing ruang auditorium FKKMK UGM lantai 1. Ruangan ini dilengkapi dengan peralatan keselamatan berupa alat pemadam kebakaran. Jika terjadi keadaan darurat di dalam gedung ini, usahakan jangan panik dan ikutilah petunjuk evakuasi sebagai berikut. Ruangan ini dilengkapi 4 pintu. 2 pintu di bagian depan dan 2 pintu di bagian belakang. Namun pilihlah pintu terdekat dengan ruang terbuka sebagai jalur keluar. Kami sampaikan evakuasi yang tepat. Lepaskan sepatu hak tinggi Anda ketika keluar dari ruangan. Utamakan wanita hamil, lansia, dan penderita penyakit kronis. Jika terjadi kebakaran, keluarlah dengan posisi merangkak untuk mempermudah Anda bernafas. Apabila terjadi gempa, maka segeralah mencari jalan keluar terdekat dan lindungi kepala Anda. Assembly point atau titik temu adalah tempat kumpul untuk keperluan evakuasi pada saat keadaan darurat. Anda tinggal keluar dari pintu dan belok ke arah kiri. Titik kumpul ini berada di depan gedung Geraha Wiyata. Pastikan jumlah rekan kerja Anda sesudah terjadi keadaan darurat. Demikian safety briefing ruang auditorium FKKMK UGM lantai 1. Kami berharap Anda tetap tenang jika dalam keadaan darurat. Terima kasih dan selamat beraktivitas.
Warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya, salam kebajikan. Distinguished guests, ladies and gentlemen, good morning and welcome to the 19th Postgraduate Forum on Health System and Policy and Action for Sustainable Healthcare 2030. Ladies and gentlemen, to start our day, we would like to extend our warmest welcome to Honorable Professor Dr. Dante Saxono Harbuono, Deputy Minister of Health of Republic of Indonesia, who are joining online with us today. Good morning, Professor Dante. Honorable President Director of BPJS Kesehatan, Professor Ali Gufron Mukti. Good morning, Professor Ali Gufron Mukti. Accompanied by Kedeputian Wilayah 6 Jawa Tengah and DIY. We also welcome Professor Dr. Laksono Trisnantoro, Honorable Professor Dr. Mubashir Hasan Basri, Head of the Public Health Program. Professor Dr. Adi Utarini, PhD, Head of the Doctoral Program. Professor Uut, good morning and welcome. Thank you. And we also welcome Head of the Departments of Health Policy and Management of Universitas Gadjah Mada, Dr. Lutfan Lazuardi, PhD. Head of Departments, Head of the Centers, and we also welcome Professor Dato Dr. Syed Mohammed Al-Junid, along with colleges and delegation from University Kebangsaan Malaysia. We also welcome Professor Dr. Supasit Panarunotai and Professor Tipawan Liab Swetrakul, together with the colleges and the delegation from Prince of Songkla University, Thailand. And also plenary speakers and moderators, we are honored to be joined today by a distinguished group of guests who are participating online, and including participants from Yogyakarta and also from across Indonesia. Ladies and gentlemen, I'm so incredibly honored and truly happy to be here today, sharing this moment to all of you in such a remarkable event. Distinguished guests, ladies and gentlemen, may I kindly invite everyone to stand in respect, and together let us take a moment to honor our nation as we sing our national anthem, Indonesia Raya. Ladies and gentlemen, please stand. Distinguished guests, ladies and gentlemen, allow me to tell you a little bit and a brief explanation of what this event is all about. The 19th Postgraduate Forum is a regional academic collaboration that began in 2007. It is co-organized by Universitas Gadjah Mada, University Kebangsaan Malaysia, and Prince of Songkla University. Organized by Department of Health Policy and Management, Center of Health Policy and Management, Faculty of Medicine, Public Health and Nursing of Universitas Gadjah Mada, sponsored by Boston Scientific Foundation, visiting professor and guest lecture grant, FKKMK UGM, and supported by Academic Hospital of Universitas Gadjah Mada, RSA UGM, BPJS Kesehatan, Doctoral Program of FKKMK UGM, and Special Region of Yogyakarta Provincial Tourism Office. The event rotates annually among the three institutions and has become a platform to share ideas and respond to pressing health challenges in Southeast Asia. And this is the 6th time hosted in Yogyakarta. Please give a big round of applause to this event. And also this program aims to strengthen postgraduate education, research exchange, and cross-country collaboration in health policy and systems. Ladies and gentlemen, our event today, the theme is Policy and Action for Sustainable Healthcare 2030. Now, without further ado, let us begin the forum. Please allow me to invite to the stage the Dean Faculty of Medicine, Public Health, and Nursing of Universitas Gadjah Mada to deliver his opening remark. Please welcome Professor Dr. Yodi Mahendra Datta.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, sawadika. Welcome back to Yogyakarta. This is the 6th time that we welcome you again to Jogja. distinguished guests, respected speakers, colleagues, students, and participants. 17 years ago, in 2008, I presented my doctoral dissertation at this forum. That time it was organized in KL by Prof. Aljunit and colleagues. I was a student back then. So no idea that I was going to be a dean 17 years later. I was 17 years younger, 17 kilogram lighter, looked much better back then. Anyway, the point is this postgraduate forum apparently is not just an academic forum, it's also been a breeding ground for future leaders. I had no idea back then that I would become the dean and return to this forum, deliver an opening remark. So I would not be surprised that 15 years from now, on the what number of postgraduate forum at 15, some of you students will come back as deans, professors, academic leaders, delivering opening remarks or keynotes on this stage. So that's actually a very good reason not only to attend, listen, and present, but also to make connections with those around you. Who knows, the person next to you several years from now may be a minister of health. So be nice to him or her. It's a good investment, trust me. So this year we gather under an important theme, Policy and Action for Sustainable Healthcare 2030. At the heart of this theme is a timeless truth once expressed by Mahatma Gandhi. He says, the future depends on what you do today. So those simple words remind us that sustainable health system which we envision for the coming decade could be built or undermined, depend on the policies we shape, the decision we make, the action we do today. Health systems around the world today face increasingly complex challenges, rising costs, demographic transitions, pandemic, climate-related health emergencies, and persistent inequities. These challenges require not only scientific innovation, but also political will, effective leadership, strategic financing, systems, resilience, and adaptability. So the work of this forum reflects exactly that mission, to transform knowledge into action and action into long-term sustainable progress. Over the next 2 days, you will explore the key levers that can strengthen our system, governance, financing, workforce, digital transformation, and partnership. I'm particularly proud that this forum for almost 2 decades now continues until now to serve as a platform for regional exchange and collaborations. The long-established engagement between Universitas Gadjah Mada, University Kebangsaan Malaysia, and Prince of Songkla University, initiated by Professor Laksono, Professor Aljunit, and Professor Supasit, who are still with us here today, demonstrate the value of shared learning and collective effort in global health. I would like to express my deepest appreciation to our founding fathers. Please give an applause to Professor Laksono, Professor Supasit, Professor Aljunit for pioneering this forum. I would like also to express my deepest appreciation for the organizing committee, the Department of Health Policy Management, the Center for Health Policy and Management, and our partner for their tireless work in making this forum a success. So let's begin this forum with open minds, bold ideas, and shared commitment to building a healthier, more sustainable world. And with that, and with gratitude, I hereby declare the 19th Postgraduate Forum on Health System and Policy officially open. Now, let me close the traditional way. In Indonesia and in Malaysia, I believe you usually close speeches with pantun. For those of you who are not familiar with what pantun is, it's a traditional poem, rhyme, usually used to close remarks like this. But this is an international forum. It's a bit tricky to do it in English. I asked ChatGPT and it looks terrible. But let me give it a try myself anyway. I just did this an hour ago. A cup of tea with lemon lime.
Cool.
A sip of coffee by the shore.
Cool.
Hope my speech was worth your time. Thanks for listening and so much more. Let me try the Indonesian Melayu version anyway. It's much, it kicks more. This one is inspired by my daughter's favorite character from the Malaysian movie Upin and Ipin, Jarjit. Dua tiga kucing berlari,
Cakep.
bawa pergi ikan tenggiri.
Cakep.
Sambutan ini saya akhiri karena sudah lelah berdiri. Terima kasih, thank you, Kap Kunka.
Thank you, Professor Yodi. Please stay on stage as we will have the opening ceremony. And to accompany Professor Yodi, we also invite Dr. Lutfan Lazuardi, head of the committee of the 19th postgraduate program, Professor Dato Dr. Syed Muhammad Al-Junid from University Kebangsaan Malaysia, and Professor Tipawan Liap Suetrakul from Prince of Songkla University of Thailand. Please proceed to the stage for the opening ceremony. We also invite Professor Laksono to join on stage, to join the opening ceremony session, please. Ladies and gentlemen, our officials are going to officially open the 19th Postgraduate Forum on Health System and Policy. And so, in my counts, Professor Yodi, please hit or strike the gong. Prof Gufron also, please. Okay, we would like to invite Professor Ali Gufron join also on stage, please, before we opening the program. Thank you. Ladies and gentlemen, are you all ready? Okay, please help me to count down from 5, 4, 3, 2, 1. Ladies and gentlemen, the 19th Postgraduate Forum on Health System and Policy is officially open. Professor Yodi, please join to the center of the stage with all of the special invitees to have the photo session. Once again, ladies and gentlemen, let's give a big round of applause. And we would like to extend our thanks to all excellencies on stage. Please back to your seat. Thank you. And now we will have a photo session together. All special invitees, please stand in front of the audience, please, bringing the handheld flags. We would like to invite all special invitees to stand in front of all audience. Professor Ali, Professor Laksono, Professor Yodi, and also all of speakers, moderator, and VIP, please stand. And all audience, are you bringing your handheld flags? All? Okay, please stand now. Everybody please stand. And please stand to the center. Everybody who stand in the left side or right side, please move to the center. Okay, we will have the photo session together. Ladies and gentlemen, let us celebrate the special program by holding the handheld flags together, facing the camera on stage, and we will have two sessions. First photo session and the second one is video session. First, okay, please again to all audience, move to the center, please. So everybody here can be captured on camera. Oke, sudah cukup, Mas? Sudah aman? Oke, baik. Alright, ladies and gentlemen, let's capture this moment by saying cheese together. 3, 2, 1, cheese! Next, Jogja. 1, 2, 3. Jogja. All right, and we will have a video session. Let us make a short video featuring our event tagline. When I say the 19th Postgraduate Forum, please respond together with better health for everyone. Okay, let's try it once before we record this. Okay, the 19th Postgraduate Forum. Okay, so now let's do it for the video with more energy and big smiles, okay? Photographer siap? Video? Okay, may you getting closer to another, please, to the center again. I'm so sorry. Okay, more closer, please, closer. Okay, again, is enough? Sudah cukup? All right, so let's try the short video. Please give your big smile and your more energy together. Photographer, videographer ready ya? Udah take ya? Okay. The 19th Postgraduate Forum! Shake your friend flag! Thank you so very much! Once again? That's okay, it's all perfect for all of us. Thank you, and ladies and gentlemen, please back to your seats. Ladies and gentlemen, we now are delighted to present to you a special performance. We invite you to immerse yourselves in a vibrant celebration of youth and grace through the Soreng Timur by Cakil Squad art community. This dance portrays the spirit of the sons and daughters of Indonesia. It symbolizes the unwavering commitment of the Indonesian people to uphold the strength and solidarity of our nation. The unity we cherish today is the result of a dynamic and ongoing process, a beautiful harmony woven from rich diversity. From various ethnic groups, languages, religions, and cultural traditions, we come together as one, the Indonesian nation. Through this performance, let us celebrate the power of unity in diversity and the collective determination that continues to shape our shared identity. Dance director, Bramantio Fendi. Music director, Sulistiono. And now, please give a warm welcome to Squad Art Community as they present the enchanting Soreng Timur dance. Thank you so very much for Squad Art community. Distinguished guests, ladies and gentlemen, next we will continue to the keynote session. A keynote speech will be delivered by the Deputy Minister of Health of Republic of Indonesia. Ladies and gentlemen, please welcome in Zoom meeting Professor Dr. Dante Saxono Harbuono.
Honorable Professor Dr. Ali Gufron Mukti, Profesor Dr. Yudi Mahendra Drata, Dr. Lutfan Lazuardi, Dr. Darwinto, Profesor Dato Dr. Syed Mohammed Al Junid from Malaysia, Profesor Dr. Laksono Triastono, and Professor Tipawan Liapsu Trakuls. Distinguished guests, colleagues, ladies and gentlemen. In Indonesia, we live by a well-known saying, sedia payung sebelum hujan. Prepare the umbrella before the rain. As a doctor, I used to think this meant being ready to treat illness, having the right diagnosis, the right treatment, the right time. But today, sitting where I do as a Vice Minister of Health, I've come to see it differently. It's not only about treating illness, but about preventing disease before it begins. That's why this forum matters, because the health system we build today will shape the life we can protect tomorrow. Ladies and gentlemen, across the world, we are facing not just one crisis, but many colliding at once: climate change, pandemic, rising non-communicable diseases, and growing gap in care are all testing the limits of our systems. And in Indonesia, we are already seeing how climate is reshaping health crises. One of the clearest samples is dengue. Historically, major outbreak occurred every 10 years. But in recent decades, driven by rising temperature and El Nino, this interval has shortened dramatically to every 3 years and sometimes even less. From 2005 to 2022, dengue incident has tripled from around 24 to 78 per 100,000 people in Indonesia. In some provinces, dengue and malaria now hit at the same time, forcing local government to declare no natural disaster. This is not random. It reflected how environmental disruption is fueling disease emergence. More than 60% of new infection disease come from animal zoonotic disease and often emerge when forests are cleared, wildlife is displaced, and ecosystems are broken. So if we want to prevent the next crisis, we must look beyond hospital and clinics. We must act upstream to protect health of people by protecting health of the planet. Let us first talk about prevention. How to stop the storm before it happens. Prevention is not just about early detection, it's about protecting forests, regulating wildlife trade, improving sanitation, investing in clean air and water, and creating resilient health cities. It is about understanding that health is created in school, in transport system, in food supply chains, far beyond the health sectors. That is why we are integrating health into all area of policy. In Indonesia, we were embedded health into agricultural, in education, infrastructures, and city planning. But it can be done by one ministry, or one country alone. We need shared solution across government, across sector, and across border. If COVID-19 taught us anything, it is that when health falls, everything else follow. And while the world might not be preparing for disease X, we already know the condition that makes such outbreak more likely: climate change, ecological destruction, and lack coordination. The best way to prepare is to act now, together, and prevent the next storm before it starts. Second, we must ensure preparedness and building strength before the shock. Since 2022, Indonesia has been transforming its health system. We are focusing on six core pillars, from the strengthening primary care and referral system to build our digital and health security infrastructures. We have improved surveillance both in laboratory and in the community. We have strengthened our community health laboratory, we call Labkesmas, and empowered our community health clinic, we call Puskesmas, to serve as our front line of defense. And this year, we have introduced Cek Kesehatan Gratis, free health checkup in every Puskesmas to catch risks before they become emergencies. We are also building our pharmaceutical resilience by increasing local production of medicines, vaccine, and medical devices. This reduces our dependence on global supply chains and allow faster response when time matters most. Preparedness is not just technical, it's strategy. It is how we protect life, ensure stability, and secure our national resilience. And third, we must strengthen our response, moving fast, reaching everyone, because when a crisis hits, speed can save life, delay can cost them. Indonesia has introduced the Reserve Healthcare Workforce Tenaga Cadangan Kesehatan. Today, we have nearly 25,000 trained health workers ready to deploy during emergency, from disease outbreak to natural disaster. We are also improving coordination across level of government, so that national and local actors respond with one voice and one plan. Through our referral network, major hospital mentor and support smaller facilities, especially in remote and underserved area. Because in a crisis, it's not enough to have system on paper. What matters that those system move, reach, and protect. And the greatest lesson we have learned is this: when we act too late, we are no longer responding. We are trying to recover. And sometimes that is too late. Distinguished guests, the question we face is no longer whether another crisis will come, but whether we will be ready. Let us not wait for the next disaster to force our hand. Let us prepare while we still can. In Indonesia, we return to wisdom. Sedia payung sebelum hujan. Prepare the umbrella before the rain. But this is not only about the weathers, it's about responsibility, foresight, and the courage to act now. Because we are not only responsible for today, we are responsible for the future, for the children born 10 years from now, who deserve clean air, accessible care, and a health system that hold strong when they need it most. Let's build an umbrella that's strong enough to protect the most vulnerable, wide enough to cover future generations, and durable enough to withstand the storm we know are coming. This is the promise of the Sustainable Development Goals: to move from treatment to to prevention, from fragmented services to strong system, from survival to well-being for all. As we reform and lead, let's be guided by one of the oldest principles in our profession, primum non nocere. First, do no harm. Let's do Let us do no harm to the community we serve. Let us do no harm to the environment that sustains our health. Let us do no harm to the future we are meant to protect. In the end, we won't be remembered by what we plan to do, but by what we build and whether it truly serves those who need it. So let us build that umbrella together. Let act with clarity and lead with care, not only for today, but for the future we all share. Thank you very much.
Once again, thank you for Deputy Minister of Health of Republic of Indonesia for taking the time today and for sharing your valuable insight. Now, ladies and gentlemen, it's time for coffee break for 15 minutes. Please enjoy the coffee or tea that has been prepared for you. This is a great opportunity to refresh and network with fellow participants. And while enjoying your break, feel free to visit our exhibition area. We have two sections of tenants, Ilmiah and UMKM, showcasing various interesting displays. And please note that after this event, the handheld flag will be collected by our committees. We also inform you that we have sent your scheduled oral presentation. Please check it out once again to your email. And ladies and gentlemen, we inform you once again that we have 15 minutes for break, and kindly make sure to return on time as we will continue with the next exciting session. Thank you so very much and have a good break.
For better health.
You can be the spark and ignite brighter care. With health policy, stronger together. You can climb higher for the best health system. With your action to achieve better health. We build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind. For better health, better health. You can be the spark that ignites brighter care. With health policy, stronger together. You can climb higher for the best health system. With your action to achieve better health. We build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind. For better health, better health. For better health, better health. For better health, better health. We better health, better health, better health. improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind. For better health, better health. Better health, better health, better health. With better health, better health, better health. Better health, better health, better health. With better health, better health, better health. Better health, better health, better health. With better health, better health, better health. Better health, better health, better health. With better health, better health, better health.
For better health.
You can be the spark and ignite brighter care. With health policy, stronger together. You can climb higher for the best health system. With your action to achieve better health. We build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind. For better health, better health. You can be the spark that ignites brighter care. With health policy, stronger together. You can climb higher for the best health system. With your action to achieve better health. We build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind. For better health, better health. For better health, better health. For better health, better health. With better health, better health, better health. For better health, better health. For better health, better health. Build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind. For better health, better health. Better health, better health, better health. With better health, better health, better health. Better health, better health, better health. With better health, better health, better health. Better health, better health, better health. With better health, better health, better health. Better health, better health, better health. With better health, better health, better health.
For better health.
You can be the spark and ignite brighter care. With health policy, stronger together. You can climb higher for the best health system. With your action to achieve better health. We build resilience, improve the health access. We can drive better health outcomes. We break chains and equity remains, leaving no one behind. For better health, better health. You can be the spark that ignites brighter care. With health policy, stronger together, you can climb higher for the best health system. With your action to achieve better health, we build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind. For better health, better health. For better health, better health. For better health, better health. We better health, better health, better health. For better health, better health. For better health, better health. Build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind. For better health, better health. Better health, better health, better health. We better health, better health, better health. Better health, better health, better health. We better health, better health, better health. Better health, better health, better health. We better health, better health, better health. Better health, better health, better health. We better health, better health, better health.
For better health.
You can be the spark that ignites brighter care. With health policy, stronger together, you can climb higher for the best health system. With your action to achieve better health, we build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind. For better health, better health. You can be the spark that ignites brighter care. With health policy, stronger together, you can climb higher for the best health system. With your action to achieve better health, we build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind. For better health, better health. For better health, better health. For better health, better health. We better health, better health, better health. we can drive better health outcomes. We break the chains and equity remains, leaving no one behind for better health, better health. Better health, better health, better health. We better health, better health, better health. Better health, better health, better health. We better health, better health, better health. Better health, better health, better health. We better health, better health, better health. Better health, better health, better health. We better health, better health, better health.
For better health.
You can be the spark that ignites brighter care. With health policy, stronger together. You can climb higher for the best health system. With your action to achieve better health. We build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind for better health, better health. You can be the spark that ignites brighter care. With health policy, stronger together. You can climb higher for the best health system. With your action to achieve better health. We build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind for better health, better health. For better health, better health. For better health, better health. We better health, better health, better health. For better health, better health. For better health, better health. Build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind for better health, better health. Better health, better health, better health. We better health, better health, better health. Better health, better health, better health. We better health, better health, better health. Better health, better health, better health. We better health, better health, better health. Better health, better health, better health. We better health, better health, better health.
For better health.
You can be the spark that ignites brighter care. With health policy, stronger together. You can climb higher for the best health system. With your action to achieve better health. We build resilience, improve the health access. We can drive better health outcomes. We break the chains and and equity remains, leaving no one behind. For better health, better health. You can be the spark that ignites brighter care. With health policy, stronger together, you can climb higher for the best health system. With your action to achieve better health, we build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind. For better health, better health. For better health, better health. For better health, better health. We better health, better health, better health. For better health, better health. For better health, better health. Build resilience, improve the health access. We can drive better health outcomes. We break the chains and equity remains, leaving no one behind. For better health, better health. Better health, better health, better health. We better health, better health, better health. Better health, better health, better health. We better health, better health, better health. Better health, better health, better health. We better health, better health, better health. Better health, better health, better
Distinguished guests, ladies and gentlemen, welcome back to our program, the 19th Postgraduate Forum on Health System and Policy. And this is the moment that we have been waiting for, our plenary session 1. We'll focus on innovations and solutions for sustainable health systems. We have 5 esteemed speakers who will be joining us on stage. And before that, please allow me to introduce our dearest moderator, who always bright up the room that he enters. Ladies and gentlemen, and this time he's going to illuminate our plenary session 1. But before that, I would like to just read out our moderator bio. He currently serves as the head of the Health Bureau at Universitas Gadjah Mada and the director of the Center for Health Service and Management at the Faculty of Medicine, Public Health and Nursing of Universitas Gadjah Mada. Dr. Andriasta earned his doctorate in public health, holds a master in advanced science from the Medical University of Innsbruck, Austria, and completed the hospital management graduate program at Universitas Gadjah Mada. He's also a member of the supervisory board of Prambanan Hospital and a dedicated lecturer at Universitas Gadjah Mada. His work bridges academic insight and health service leadership, particularly in hospital and health system strengthening. And last but not least, let's give a big round of applause to our moderator, Dr. Andriasta Meliala.
Distinguished professors, speakers, colleagues, students, and all of the participants, welcome to our first plenary in this our 19th POST Forum. It's an honor and a privilege to welcome you all to this session. So in this session, we would like to discuss the 2 issues that really hot topics in our time. Currently, we are facing a very confusing and also very disruptive era in this period. First, we would like to discuss about the strategy for green planets, and we have the representative of the environmental health of the Ministry of Health of Republic Indonesia. And then we will have also the director, the president director of Academic Hospital of Universitas Gadjah Mada. Then the second issue that we would like to link is about the health financing in the healthcare. So as we know, our healthcare contributes around 4 to 5% of global carbon emissions. And then we have also a very big challenge in the how to finance our healthcare to achieve a certain standard of quality. So to link these 2 issues, we have experts on health financing. We have our legendary professor, Professor Dato Dr. Syed Muhammad Al-Junaid from the UKM and IMU, Malaysia. And we have also the President Director of BPJS Kesehatan Indonesia, Professor Dr. Ali Gubron, is also an academician from the Department of Health Policy and Management in this university. And other expert in the health financing, we will have Ibu Prastuti Suwondo. She is a special advisor on health financing for the Ministry of Health. And as I mentioned before, to close the session, we will have the experience of the President Director of UGM Hospital, Dr. Darwito, to share his experience about how to develop the green hospital in the context of academic health system. So without further ado, we will have two online presentations from Ibu Christine Darundia. She is the representative of Environmental Health Directorate of the Ministry of Health, and also Ibu Prastuti Suwondo. But we would like to invite the speakers to come to the stage. First, we will invite Professor Aljunid. Please welcome to the stage, and we will give a big applause for our professors. We also invite Professor Ali Gubron. Please, Professor, come to the stage. We can sit over there, or you can sit over there, Professor. And also Dr. Darwito. Yeah. We give a big applause for our three speakers who are already with us in this auditorium. And we have Ibu Christine and Ibu Prastuti on the line. So first, we would like to invite Ibu Christine Darundia. Ibu Christine, are you with us now?
Yes.
Yes.
Is my voice clear,
Yes,
Mr. Andre?
very loud and clear. Thank you so much.
Okay.
Okay, Bu.
Thank you.
Please share your presentation. We have a very limited of time, so we'll give you 20 minutes, Ibu. And please, yeah, we give again big applause for Ibu Christine Darundia.
Is my presentation already on the script? Thank you, Mr. Andre, for the time, and thank you for an organizer to invite us.
Recording in progress.
Ministry of Health, Directorate of Environmental Health. We have chance to give a presentation in this great event. I'm so sorry because of my director, Ibu Ten, at the moment still on offline on the United Nations Climate Change Conference in Bonn, Germany. So I will replace her to give the presentation at the moment. Sorry for this inconvenience. And I will start for this presentation. Ladies and gentlemen, good morning, and thank you for this wonderful conference today. My name is Christine Darundia, as a specialist in environmental health in the Ministry of Health of Indonesia. At the moment here, I would like to present environmental health strategy to address the global health. The outline of this presentation is Indonesian legal framework, and then Ministry of Health, Republic of Indonesia strategic plan target, and Indonesian healthcare facility strategy for sustainability. As you know, that antimicrobial resistance, AMR, and climate change are growing global threats that worsen environmental health risk on the water sanitation and hygiene, and in healthcare facility. AMR spread through untreated waste and safe water and sanitation, and poor hygiene, while climate change increase extreme weather that disrupt waste infrastructure, reducing the resilience of healthcare facility, endangering patient safety. The world is facing multiple health challenges, and based on that, I also refer to WHO and health partner in 2019 that already identified that there are 10 of the many issues that will demand attention, which is two of them are air pollution and climate change and weak primary health care. And the overall climate resilient health system framework, as when framing of improvement toward climate resilience and environmental sustainability of healthcare facilities, they may have to also strengthen other components such as integration of weather climate information in the surveillance and influence significant stakeholders at the national or regional level to implement. The relevant the chart of relevant implementation regarding with the climate change adaptation and mitigation, such as policy related to water, sanitation, hygiene, or water, energy, and seating of the infrastructure. Focus area climate resilient health at the addressing the multiple health impacts of climate change, strengthening climate resilience and environmental sustainability of health system and facilities, and promoting health co-benefits of climate change mitigation in other sectors. Uh, uh, we also refer to WHO guidelines 2023 that the implementation of climate change mitigation and adaptation effort is carried out in order to achieve the health sector contribution target and realizing national determined contribution through 10 building block of climate resilient health system. There are our activities that have been taken and have been done at the moment related with the climate change adaptation in health sector. Uh, environmental health strategy for sustainability is developed to addressing global threats of antimicrobial resistance and climate change. This includes some activities building information system for optimal use of waste for risk-based assessment by healthcare facility, enhancing healthcare facility through improvement water sanitation and hygiene service upgrade, and mainstreaming gender equality, disability, social inclusion. Or we make abbreviation GETSI, climate resilient and antimicrobial steward, AMS. Addressing AMR and climate through IoT-based digital risk management involve leveraging Internet of Things technology to develop an integrated medical risk information system, enabling real-time monitoring and data-driven decision-making for healthcare risk, and strengthen public-private partnership on medical risk management based on data. Healthcare facility enhance their water, sanitation, and hygiene service through the structure 5-step WASH facility improve tools, WASH fit, training, assessment, prioritization, improvement, and evaluation. Developed based on the WHO UNICEF Joint Monitoring Program framework, WASH fit provides a systematic approach to upgrading WASH service. In Indonesia, this initiative gained additional importance as WASH compliance is integrated into the national healthcare facility accreditation system, ensuring sustainable improvement in facility quality and patient safety. The digital WASH-fit platform enhances risk-based assessment in healthcare facility through an integrated information system that streamlines water sanitation and hygiene improvement. By leveraging data analysis and monitoring, it enables facility to identify risk, prioritize action, and optimize decision making. The platform also mainstream gender quality, disability, and social inclusion, or GETSI, climate resilient and antimicrobial stewardship into routine of operation for sustainable health environment. The digital information as the digital information system optimized WASH-fit utilization by enabling risk-based assessment through integrated data analytics. The system streamlined WASH infrastructure improvement while systematically mainstreaming GETSI, climate resilient mission, and AMS standard into facility operation, transforming fragmented processes into a unified, data-driven approach for sustainable health improvement. This is the picture dashboard of the MISMILE, because electronic immunization and logistic monitoring system for waste. It's a mobile application and web-based information system designed to digitally manage hazardous waste from healthcare facilities. The system provides the record including waste, source and type of waste, time and location of storage, transport, and tracing waste transport and waste treatment methods developed by the MOH, Ministry of Health of Indonesia, in collaboration with the United Nations Development Program or UNDP. This electronic addressing climate change by reducing the use of paper for manifest of reporting. MISMILE utilized, as we saw in this screen, actually as a simple utilized Internet of Things technology integrated with the small smart scale and quick response atau or QR code for waste identification and tracing. The smart scale are battery powered, ensuring uninterrupted operation in healthcare facility with limited electricity access. Bluetooth connectivity is used to transmit data from the smart scale to smartphone, which then synchronized with the MOH data storage. Once an internet connection, Wi-Fi or mobile data becomes available. The implementation of the environmental health and waste management and healthcare facility is relevant and support the achievement of SDGs indicator, quality, good health and well-being, call on countries to ensure health life and promote well-being for all at or it. And also goal 6, ensuring availability and sustainability management of water and sanitation for all to ensure no one left behind. So finally, I will give to summarize the last but not least the conclusions, which are climate change and IMR combined was vulnerability accelerating IMR threat. So integrated strategy are needed to address climate change and IMR enhancing sanitation, and also the legal framework for climate resilient, environmentally sustainability, healthcare facilities through implementation of 10 building blocks of climate resilient health system, including optimizing waste fit implementation and using IoT-based digital waste management to address IMR and climate change. Environmental health alignment with the goal 3, good health and well-being, and also goal 6, ensuring availability and sustainability management of water and sanitation for all of SDGs. And the last slide, just thank you. That's all my presentation. Thank you so much.
So thank you, Ibu Christine. We give big appreciation for Ibu Christine that already share her presentation about the national strategy for the planet objectives in the Ministry of Health. So before we move to the next speaker, Professor Said Al-Junaid, so at the end of the session, we will summarize all the presentations. I would like to ask one student to do to summarize our discussion, and we have a door prize for you. This is a very valuable door prize. This is very green door prize. This is very memorable for you. And it will be handed by Professor Al-Junaid and also Professor Gufron. So, Professor Al-Junaid, time is yours.
Thank you, Dr. Andrea. And first of all, I would like to thank you for inviting us for this plenary. Prof. Gufron, this is a bit unusual plenary because we are sitting down. Maybe Prof. Supasit, they think we are too old already. That's why I asked us to sit down. You know? Okay, I want to talk about a bit on the health financing universal coverage. I think besides me, Prof. Gufron, who is the main person who is actually involved in implementing the biggest health financing system in the world today, the social health insurance. I think the BPJS have gone very far. Malaysia, we have to learn a lot more. Okay. I want to touch a bit about what we did in London School of Hygiene 30 years ago. When three of us were studying there, myself, Prof. Sono, and Professor Pasit, we were guided by one of the professor in health economics and meals. And she talks about universal health coverage at that time. And when I came in and three of us were studying, we were struggling to understand the concept. But it's very interesting because Malaysia in 1985 has declared that we have achieved universal health coverage. 1985, when I graduated. But one thing that we told everybody from the health policy side is that it does not mean that once you achieve, you can easily maintain it. And now, the healthcare system in Malaysia is having a lot of problems. Okay, you are lucky in Indonesia because you have BPJS that runs the JKN. We are still struggling today to do that. So, what is universal health coverage? We want to make sure that everybody have access to essential health services without affecting their financial hardship, the social, economic status, for example. And of course, we know that this is a very important aspect. I would say that if we have a good health financing system, maybe 50 to 60% of issues in health system can be solved. But of course, people always say that money is not everything. But if you have it, it's very, very useful, So that is important. So in 2007, Ann Mills proposed this as a concept, and it came out in Lancet at that time. Universal health coverage is a situation where everybody in the country would have access to good quality services, okay? Without actually, this access should be actually be sort of affected by their preferences, their needs for healthcare, but it should not be determined by their ability to pay, and also their income status as well as social status. It's very, very important. Social status, another thing. In Malaysia, it's very important here. If you know someone, you can bypass the waiting list. That is very important. Last night, my daughter called me. She's going to be admitted. She has impacted this one fishbone, middle of the night. And then, if you follow the usual protocol, you know how many days you want to get the access to the ENT surgeon. But not Indonesia. In Indonesia, you can go to private hospital. Here in Malaysia, you're going to go to private hospital, you have to pay a lot. But social status, when they know that that's my daughter, within 30 minutes of waiting time, she got the access. This is not good for general population. And that is important for us to understand. So it's important for us to know that we want everyone to be able to access the healthcare services without financial hardship. And we want to cover the most vulnerable in the population, which is the poor. This is in Philippines when I was visiting them some time back during our DRG meeting. Yeah? This is one of the area in Quepo, around Quepo Mosque. If you are from Philippines, you would know this. People come from all over the place, and then they become squatters in the area. And at that time, I think PhilHealth is still struggling to provide these services for the poor. We want to cover a range of services, but of course, we need to define what can be covered and what cannot be covered, because it's impossible to cover everything under the sun. So essential services need to be properly defined. And one more important thing is that whenever it comes to cost, individuals will not be able to cover their own costs. We need to have a pool resources and sharing of risk. And we must also make sure that access should be based on need rather than ability to pay. If you base on ability to pay, there will be a lot of people who are not afford to pay. This is the situation today on universal health coverage. You can see middle income country and low income country are still struggling. We are probably achieving 50% to 60% of what we're supposed to achieve in terms of the coverage. Not much happening. I think one of the reasons why is it because of the increase in prevalence of chronic non-communicable diseases. In 2023, this is the WHO report, only 42 countries achieve probably more than 80% of the index of coverage. Most countries are below that. Malaysia is one of the 81 countries that actually scores below than 80%. And I would say many of these countries are still struggling. And you can see that even 14 countries in the world have only about 20% coverage, you know. So this is, that means that there's still a lot of things that we need to do. One of the major things that we need to look at is basically the financial situation. We don't have enough resources, and government is struggling to actually provide this. And if you don't have system that you have in Indonesia, the national health insurance, the country will be at great disadvantage at this point of time. And we should have started this long time ago. But Indonesia picked it up first, and they are now moving forward than many other countries in the world, including Malaysia. The second issue is that if you depend on ability to pay, you lead to high out-of-pocket expenditure. In Malaysia, our health out-of-pocket expenditure in terms of the total health expenditure is about 36%, which is one of the highest in the world and also in the region. What's the problem with out-of-pocket expenditure? It means that you're not sharing the risk, you're not sharing the financial resources, and it will lead to high inequitable access to these services. Furthermore, we have a problem of fragmentation of the funding mechanism. We have out-of-pocket expenditure. We also have the other things that coming in to provide the resources, including taxation. Malaysia is launching SST, the sales and service tax, at the end of this month, 1st of July, and we are struggling with that because a lot of resources may not be able to be raised so much from SST, especially for health. This is the current situation in terms of the impoverishing out-of-pocket expenditure. If we look at the purchasing power parity, and you look at the poverty line of 2.15 cent poverty line, you can see there is a drop. But if you look at the relative poverty line, which is more relevant figure, you can see that currently we nearly have 1.2 billion people in the world that are actually impoverished because of their healthcare services. This is the main thing that universal health coverage wants to protect. 1.3 billion of these of people who are actually suffering from this, and they become poor because of their illness. Something that Prof. N. Mills and the team are trying to convince World Health Organization and also other healthcare players to avoid at that time, you know. So what are the barriers? Of course, the main barriers is that inadequate public funding. In developing countries, we are spending between 3 to 4% of GDP. If you look at the global average, it's about 10%. And in European region, it's about 11% of GDP. We are actually having resources only to manage half of the whole thing, you know, 50% of that. And if you rely too much on out-of-pocket expenditure, you lead to a lot of problem with those people who cannot afford to pay for the services. And if you have multiple sources of funding, we're just talking to Prof. Gupron regarding single payer. Yeah? If you have multiple payer, you fragmented the system, issue of inefficiency is there. A lot of resources might be used to actually manage the system. I think at one time WHO was saying that whenever you use operational costs more than 10% for national health insurance or social health insurance, it will not be sustainable in long term. So if you have multiple payer system, you not be careful, then we will have a lot of issues with that. And of course, we know that on the demand side, we have issues of risk in non-communicable diseases. 1 in 5 of Malaysian population are having diabetes at the moment. And 1 in 3 will have issues of hypertension. All these diseases, including cancers, yeah? And our breast cancer, for example, the outcome of care is also not very good. All these conditions which need long-term care and very expensive. Especially now we have new modalities of treatment which does not come cheap. We have people who are promoting bone marrow, stem cell treatment and all that, you know. This is not cheap. At the same time, we are having an aged population, which actually put extra strain to the population. I think most of the developing countries are moving toward aging population. And of course, we were unlucky to have a COVID-19 pandemic in 2019 to 2023. We are not sure whether what will hit us again in the future. And you know very well that when we have health emergencies, a lot of issues happening. We need a lot of resources. At the same time, policymakers take advantage of this emergency system to siphon a lot of money because they don't have to go through a proper tendering process when it award the. I think our last two prime minister, who served during the pandemic, are now being in court today for abuse of resources. So that's another important area that we should look at it. So what is the future direction? We are talking a lot regarding problem, but what we want to do actually to solve this. Number one, we must actually work to mobilize resources, and then we must also promote pool funding, and we must move away from reliance on user fees. London School of Hygiene did a lot of work when user fees was actually promoted or proposed by World Bank back in 1987. We know that user fees will not actually solve all these issues. We need to implement strategic purchasing so that we can actually get value for money, expand the social health insurance scheme. Our bias is toward a single payer system. I think this is what we should do. And we should actually capitalize on the digital solution as much as possible. Government must take the initiative to do this, and we must actually settle the issues of financial requirement. That is one of the important things. Political will is very important. In Malaysia, one of the reasons is because
we should move forward to the next speaker, Professor Ali Gubron. Since Professor Aljunied mentioned, Professor Ali Gubron is the president of the biggest social health insurance. So we give Professor Gubron additional 5 minutes time, Prof. Yeah, so 20 minutes for you. Yeah.
Okay, first of all, I would like to thank Assalamualaikum warahmatullahi wabarakatuh. A very good morning. And of course, can I mention some of our colleagues? Honorable Dr. Yodi Mahendra Datta is the Dean, Faculty of Medicine. And when actually he mentioned that one of you maybe will be the Vice Minister or maybe Minister of Health in the future. I think it is already one of us already as the Vice Minister or Acting Minister of Health of at least of Indonesia. Yeah. We can approach to Dr. Yodi. And of course, Prof. Laksono, thank you very much. Prof. Mubasir, the new professor. Also Dr. Lutfan Lazuarti, Prof. Adi Utarini, and of course Prof. Wirafat Sakti. We graduated from the same university, Prof. Supasit, and also of course, you know, our Dato, who already as the founding fathers, and the Pawan, also, you know, Prof. Husni. I think, yeah, we met already, Dr. Christine. And from BPJS, Dr. Yesi, who responsible for DEA and also Central Java. And of course, Prof. Kwazi, Prof. Rizal. We already also discussed about primary health care, especially family medicine. And Bu Dia, Ayu, Bu Citra, also, I think the most important is, you know, implementing BPJS in the hospital, Pak Darwito, okay. Yeah, I think he will tell how actually BPJS is done in the hospital. Okay, ladies and gentlemen, now we start. I think I'm lucky because you already explained USC, so no need for me to explain USC. Next slide then. So this is the Indonesia. Next slide. As you know that actually, Pak Ontong, Bu Rini, I think it is very important because Pak Ontong is former Secretary General of Minister of Health. That time also he contributed, you know, 3 prominent persons in the world, from the President of Indonesia, Prime Minister of UK, and then President of Liberia, who drafted the SGD actually. That time come out to be 12 goals. Then by United States, by United Nations, it was improved to be 17 goals. And now we are discussing number 1 goal and also number 3, good health and well-being. Next slide, please. Yeah, so for SDG 1.3, implement nationally appropriate social protection system. And we, that time, you know, in United Nations, WHO, we trying together with our colleague from Thailand to make sure that this should be adopted as the, you know, United Nations resolution. And basically, SDG number 3.8, achieve universal health coverage, including financial protection, access to quality essential health services, and access to safe, effective, quality, and affordable essential medicine and vaccine for all, health system strengthening. So this is actually what we are now trying to, you know, discuss. That time in Yogyakarta, there was a book entitled, "It is Forbidden to Fall Sick for the Poor." But now I changed, it is forbidden for the poor if they fall sick to pay, because if they are actively member of BPJS Kesehatan. Okay, we can give applause because from forbidden to fall sick, now forbidden to pay. Okay, next slide please. So this is the USA. I think I do not want to explain, but again, in Indonesia, BPJS Kesehatan is not under ministry. It is directly under president. And there are 2 sides when we are talking about health service, our health system, at least supply side and demand side. BPJS is concerning demand side. Supply side is not responsibility of BPJS. So when we are talking about doctors, about the health infrastructures, it is not responsibility of BPJS Kesehatan. Next slide, please. So this is the BPJS Kesehatan. You know, we should make sure the equitable balance between finance, government, and healthcare. Next slide, please. So actually, again, we are public legal entity and not for-profit business entity. So we are not for-profit oriented legal entity. So this should be understood. Then, of course, the funding from government also, but the funding from government should be directed to the poor, and it is according to the Constitution. Next slide, please. So again, demand side, and when you are talking UKM, public health measures, this is not under BPJS. This is under the Ministry of Health, under the local governments. And this is the task of BPJS. Next slide, please. So again, the model business of JKN, JKN is the program, BPJS as the you know, executing agency who run the program. So basically BPJS have 3 functions: revenue collection, risk pool, and strategic purchasing. How to purchase strategically through primary health care? We use what we call it performance-based capitation. So therefore, we have to be able to monitor all performance of primary health care in the countries. And then, of course, now we have a quality transformation. You know, quality transformation actually, when we are talking about the conceptual framework of Dona Bedian, it is complicated, but PPJS make it very easy with 3 only indicators: easier, faster, non-discrimination. And we are lucky to Professor Aljunet because have to build the INA-CBGs. And even in Malaysia, it is not yet implemented well, but in Indonesia, it is already implemented across the country, both private hospital and public hospitals. Even in private hospital who contacted the BPJS, already 65% of all hospitals contacted by BPJS is private hospital in Indonesia. And you know, when we came to BPJS, so it was still deficit, but then suddenly positive, yeah, surplus. Then the coverage is 98.21% coverage, and we give the down payment. We make sure that cash flow of the hospital will be okay, and satisfaction out of pocket, you know, from 49.7% down to 25%, yeah, 25 to 28%. Okay, I will not talk about. Okay, next slide, because of the time. So now that is the reduced auto packet, improving healthcare access, many things. Next slide. Yeah. So okay, that is the number of hospitals. Okay, please. That is the number of utilization a day now. Previously, it's only 252,000 a day utilization. Now it's 1.9 actually, not 1.8. 1.9 million. And all this transaction is captured. So when we are talking about postgraduate student, the problem is most of postgraduate students do not have problems. So the problem is do not have problems. Yeah. So I said to many students, postgraduate students, if you would like to have problem, please come to BPJS. There are many problems. Like that. Okay, next slide, please. Next slide. Okay, that is 175 trillion, or at least that is around 11 billion US dollar under our management. Okay, and 37 just for the catastrophic spending. Next slide, please. So that is the name of the diseases. Next slide. Yeah, this is we have to make gatekeeper to primary health care. Next slide, please. Next slide. Yeah, this next slide, please, to be very fast. Okay, next slide, please. So we'll be finished here. Next slide. This is the primary care in Indonesia. Next slide, please. Yeah. So primary care, because that is the problem what actually explained theoretically by Prof. Aljunet, but in reality, that is what actually happening. Next slide, please. Yeah. Okay. That is promotion and prevention. Now in BPJS, we offer not only when they have birth date, but every time, every minute, they can use screening. By what? By download mobile CKN and answering screening of history taking, of history, health history. Then they answering around 47. Then this mobile CKN suddenly will provide you information that you are high risk of, for example, like hypertension or heart disease, something like that. So next slide. So then you should come to the clinic, your clinic or primary health care, to check your thing, and BPJS will pay. So now this is the next slide. Yeah. So this is the health promotion, health screening. Next slide. Next slide. Okay. So this is, as I mentioned, our population classified into 3 groups: healthy people, and then risk people, and then sick people. For the risk people, we make 3: primary prevention, and then secondary prevention, and tertiary prevention. Next slide. So this is the example. Those who already, around 44 million people, Indonesian people, who already answered the screening using mobile CKN. Okay. So 1% of them actually risk of diabetes mellitus. Then this mobile JKN suggested to come to primary health care or clinic, then to measure the glucose level in the blood. Then 51% actually diabetes, out of 1%. Next slide, please. And also the cancer. So now that is the people, and we have chronic disease management. Next slide, please. So everything is paid by BPJS. This is mobile JKN for members. So it is super apps. So many things, not only screening, but they can register, can complain, even after services was given by clinic or by hospital, they can rating, yeah? Give 1 star, 2 star, up to 5 star maximum, not 7 star. Kalau 7 star, it is bintang 7, is jamu, or maybe they consider pusing, yeah? Pusing keliling. Next slide, please. Even we have what we call it bugar. So bugar, you know, BPJS now provide, if they exercise, how many steps, it will be calculated, how many calorie, energy. But the problem, especially the rich, and I think people here is middle income class earners and rich, so you must do not know, yeah, and do not use. And it is good because if you do not use, because otherwise we have to pay you. Yeah. Next slide, please. So that is the digital health services. Next slide. Telemedicine. Now we have video-based telemedicine. So the doctor can see the patient can see the doctor. Next slide, please. Next slide. Yeah. This is the iCare JKN. So people in Jogja go to the hospital. Doctor in Jakarta can know it. So we have real-time data and provided more than 100 million data can be assessed and analyzed by all academicians, including yourself. Next slide, please. Next slide. So, okay, click. So there is many people come
coming to see the command center. I found the command center also something that is remarkable. I mean, that it helps you to get a feel of what is happening on the ground, and then how it is being used also to drive enrollment and all. I think I'm highly impressed. Yeah.
So to come back to Indonesia and to see BPJS now and what it's achieved is really quite impressive. So I congratulate everyone who's worked on BPJS. It's amazing to see the level of coverage across the country and to see the attention to equity and meeting the needs of the population. And I think I'm still learning about BPJS, but what I can say is I'm impressed with how much it is innovating and testing and experimenting with new things. To me, the things that are most exciting are the things that make healthcare different for the individual. So making access easier, bringing services closer to the individual or to the community. I think the ways that BPJS is innovating and finding ways to do that, that's what impresses me most.
Impressive. So the coverage that BPJS has is something that many countries aspire to achieve. So in many ways, it's a place that we can look to learn and see what's being done here that we might be able to transfer and use in other parts of the world that are not as far along in different aspects of health. The integration between levels of the health system and from providers to BPJS is something that's really stood out. So the way that the technology has been used and information is shared to provide better care for the population is something that's been really impressive, and I'm excited to learn more about it.
I was very impressed by the digital transformation, and I can't imagine how they handled 1 million insurance claims a day. So I was very impressed by how efficient the leadership, how efficient the management of everything was. So I think Indonesia's experience with JKN has not only been aspirational, but it's also been inspirational to a lot of countries which come from the same context, lower middle income countries that are aiming to achieve universal health coverage. The experience that Indonesia has had provides invaluable lessons to many countries that are on the same path, which Indonesia has almost achieved near universal, decreasing out-of-pocket expenditures, improving service delivery quality, as well as improving efficiency. So I think the world is looking towards Indonesia for your country experiences and how we
can go back and emulate the same in our country.
BPJS keren.
BPJS Kesehatan keren.
BPJS Kesehatan keren.
So keren meaning cool. So the US say that BPJS is keren, but not Indonesian. So now I can bet to you that actually Indonesian JKN is already overtaken US, because in US more than 35 million people not yet covered. Okay, because you add 5 minutes, so I need 5 minutes? Yeah, okay. Oh, 3 minutes, okay, 3 minutes. So, okay, so we were invited in United Nations to talk about the BPJS. Next slide, please. And we were invited to give lecture to many, to Harvard, Johns Hopkins, Melbourne Uni, and many things. Next slide, please. Next slide. So, okay, so this may be 1 minute and another 1 minute. Okay, 1 minute. Yeah. This is competition done by ISA. ISA is International Social Security Association based in Geneva with 162 member states.
Yes, and now the winner can be announced. So I would like once again to congratulate all member institutions who took part in the competition. It was impressive to see the range and scope of the submissions. The one award we have not yet announced is, of course, the overall winner. So, from 168 entries in the jury had to select one that was outstanding and deserved to be awarded as the winner of the competition. So it is my great pleasure to announce the winner of the ISA Good Practice Award for Asia and the Pacific for 2021. The winner is the Social Security Administrating Body for Health, BPJS Kesehatan, Indonesia, for its National Health Security Program.
Because we have to, have to promote, and we have no budget. If we have budget, we will hire professionals who sing very well and compose the song to educate people. Because we have no budget, then we create ourselves. So we create, it is like Bu Christine already explained. Okay, we just maybe another 1.5 minutes. Next slide then. Okay, 1 minute, 1.5 minutes. This is our office. So you should not regret, you should promotion and prevention.
Baru tahu kesehatanku ditentukan perilaku dulu orang tuaku dan tetanggaku, kesehatannya kini terganggu. Menyesal sejak dulu lingkungan dan perilaku tidak terjaga dengan bermutu. Semua telah berlalu. Olahraga
senang hati.
Menyesal sejak dulu lingkungan dan perilaku tidak dijaga dengan bermutu. Semua telah berlalu.
Assalamualaikum warahmatullahi wabarakatuh.
So no wonder that the participants of BPJS is 270 million because the president director himself do the marketing directly. Thank you so much, Prof. Gufron. And we move forward to Ibu Becky. Good morning, Ibu Becky.
Good morning. Apakah suara saya terdengar?
Yes, loud and clear, Ibu.
Okay, thank you.
Yes. So please, Ibu, I heard that you have only 10 minutes or 15 minutes. Please, Ibu, without further ado.
Thank you, Dr. Andreas. Very good morning to all of you, all the distinguished Professor Yodi, Professor Aljunet, Professor Ari Gufron, Professor Laksono, and many other colleagues, guests, and postgraduate. Thank you for inviting me for this preliminary session. I would like to use campur-campur bahasa, nggak apa-apa ya, Pak Andreas? Okay. I was assigned to present, to share with you with innovative financing for sustainability health systems. And I'm sure this is not new to all of you. I would like to start with the perspective of health financing in Indonesia. As you know that in Indonesia, the Ministry of Health produced the National Health Account, and from the macro perspective, this is our profile, the financing profile. As you know that the total health expenditures per GDP is quite low. It's about 2.9% when you count as total health expenditures, and then the proportion of public and private, the role of public schemes is about 57% according to the 2023 years. And then what we can see in here, I would like to highlight the red color is the portion of the social health insurance led by Professor Gufron. Professor Gufron, thank you for your inspiring video. So the role of the social health insurance comprises of 27% of the total health expenditures, and it's growing quite fast from 47 trillion or represent about 14% up to 27% now. What is also the achievement is the role, the proportion of the auto packet. Auto packet in 2014, when the BPJS started, it's about 43% of the total health expenditures. But as the public scheme growing, especially the social health insurance, then the out-of-pocket reduced to 28% in the figure of 2023. So this is all a good news, but we also still a challenge because the total health expenditures per GDP is quite low. That will be represented on the next slide. So this is the next slide. This is the financing profile across countries. As you can see that the public spending is 51%. And this is a figure of 2022. And as you can see that we are the number 3 from the bottom. And then the private health insurance, on the bottom left is only about, I think the Indonesia about 4.4%. So this is also the Ministry of Health trying to encourage the growing of the private health insurance to complement the growing of the social health insurance. And as I already mentioned, this is a figure of 2022. The proportion of out-of-pocket is 33% and reduced to 28% in 2024. Okay, next slide. Yeah, next slide is about that Ministry of Health is undergone the health transformation. This is the transformation house. I'm sure that most of you are familiar with the 6 pillars that we are experienced with, and this transformation is started in the 2022 and still ongoing. And as you can see, the pillar number 4 is the health financing transformation. So we would like to ensure that the financing is sufficient for the primary care, for the secondary care, as well as we also want to introduce the health system resilient transformation, and as well as an enablers. In addition to health financing, we also want to make sure that the health talent transformation, the distribution of specialists, health manpowers, and as well the health technology transformation, including the digitalization. Okay, next. We also want to share with you the innovation financing for sustainability health systems. So I would like to, because of the time constraint, I would like to also emphasize on the point number 2, the outcome-oriented and risk-sharing models. So in the outcome-oriented, we focus on measurable health outcome, not just focus on the inputs and activities, but also link between the spending and the output. So this is based on the performance base. And then risk-sharing models is also, we have piloted in TB program, strategic health positioning for TB. And with this piloted, we also acknowledge that not only the notification increased substantially, but the involvement of private sectors is also increased. Okay, of course, the other is sustainability and efficiency, the other characteristic of innovative financing. And then the next one, why we need innovative financing. I think Professor Gufran already lay out many efforts, many policy in the JKN for innovative financing, but we still, since our health system is quite complex, then we still have an ongoing innovative financing. As you know that sustainability become an issues in here, and then efficiency and accountability continue to be as part of the important things. And then we also want to continue for expand access. Prof. Gufron also mentioned that supply side is our success, one of the success part for achieving universal coverage. So we also improve from the supply side perspective. Okay, and then on the next one, next slide, please. Yeah, this is just give you an examples of the innovative financing mechanism. This is some that innovative financing mechanism that has been implemented, and then there is the last point is the one for the next agenda that we are in the process of discussing. So in the public-private partnership, as you know that we already have develop a collaboration with the government and the private firms, to build and operate hospitals and then mobile clinics and CSR-driven health services, companies and public and private, for instance, like cataract surgery, maternal health programs, this is, and then digital health. And this is actually want to expand access, especially to underserved, and we some strategy to mobilize the additional funding for this. And then the next one is the syntax. This part of the policy that we are already implemented, for instance, like a tobacco tax. And we acknowledge that every year the price of the tobacco substantially increase, And then we also want to impose the alcohol tax. The alcohol tax already there, apply a different level of percentage for different level of alcohol. And then this is the thing that we are still on our agenda and plan to be implemented in 2025, still under this discussion. So we would like to apply the sugar drink tax, thinking about 2.5% of the sales. This is targeting because, as you know, from the free medical checkup, we acknowledge that there is a quite substantial increase in diabetics and hypertension. So I think we would like to impose and still on the discussion with the line minister. We believe that if we impose this syntax, expand it and effectively implement it, we believe that there is, in addition to significant revenue generation to the government, but we also has a reduced potential risk, for the healthcare costs. Okay, next. Okay, this is the result-based financing. I think Professor Gufron already shared with us that the performance-based capitation, how the behavior of the providers change based on the performance, you know. So it has been implemented, but we also need to continue to improve so it really become efficient and effective. In addition to that, there is some massive infrastructures upgrade, revitalize 300,000 posyandu, 10,000 400 puskesmas, and also as the Vice Minister just mentioned about upgrading the 514 public health labs. So, and then with the prevention, we also focus, funded by the central budget, on the free medical checkup. And this is one of the things that we also have to follow up based on this. And then what is our next agenda? Our next agenda, since we know that financing is important to link between the spending and the output, then in the primary care, especially on the primary care, we acknowledge that there is multi funding, multi-source of fund, and then in the implementation, we know that there is many public financial management issue. So working together with the World Bank, we are trying to find a solution for this one, you know. So on the right side, we are thinking about the 3 level of public financial management reforms. This is still in the discussion. We are doing it in stages. So the purpose of this is we want to optimize the use of the resource, the available resources to be optimized. Yeah. So the level 1, we streamline the planning and budgeting, and then the level 2 next, we are considered the treasurer, because as we acknowledge there are 4 or 3 treasurers in the puskesmas when they operated. We try to introduce a single bank account portal, and this is under this discussion with the Ministry of Home Affairs that allow inter-account loan. You know, as you know that BOK money always come not in the proper time, so activities for public health are still be executed. And then level 3, more advanced, maybe 2 or 3 years from now, as the times allow, then we will go to the next advanced level. And then the next, my last slide, is the global budget in universal health coverage. As you know that social health insurance has implemented the prospective payment systems, paying capitation and non-capitation for the primary care, and DRGs for the prospective payment system for the hospital. So what we know is from the experience, we know that the spending of JKN continue to increase, but the proportion of primary care reduce from time to time. So when it was started, the proportion of primary care is about 18%, and now after 10 years, more than 10 years implementation, the proportion for primary care is about 12%. So why it happens? Because when you introduce capitation, I think it's controlled. There is risk for cost escalation is quite minimum. However, the cost of hospital has incentive for them to increase the utilization. So what we are thinking, maybe we are thinking to impose one more tools to complete the health financing as overall. So we will thinking to design a formula. What is the proper formula for global budget apply in Indonesia? We acknowledge that there is no one fit for all. So when JKN has a pilot project on the global budget in 2019, but not yet continue, but the concept is very good. So we continue to thinking design on the global budget for improving as a concept for cost control. So what is the key message for the financing? I would like to maybe start with what the spirit that this workshop is spend more, spend better. So I think value of money has become very important in here. And then we also has to focus on equity, but also sustainability of the So supply side, we want to make sure that access is equitable, equity, not equitable. And then also we also want to continue thinking about introducing new funding models and improving coordination across sectors, especially with Ministry of Home Affairs, Ministry of Finance, of course, and Ministry of Village. So I think of course, we have to align the health financing with the health system transformation that's undergone under the Ministry of Health. So that is our presentation. Hopefully it will give inspiration to you all. Thank you.
Yes, thank you so much, Ibu Becky, for your very clear presentation and also the way forward and transformation of financing system in Indonesia. So we already seen so many innovations proposed by on the way to be implemented. So our final speaker is the President Director of Academic Hospital of Universitas Gadjah Mada, Dr. Darwito. Please, time is yours.
Thank you. I'm sorry, I use bahasa Indonesia. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Saya mohon maaf menggunakan bahasa Indonesia. Slide. Ini adalah bagaimana perjalanan salah satu rumah sakit yang ada di Indonesia, yaitu rumah sakit akademik yang dimiliki oleh Universitas Gadjah Mada menuju Gogri Hospital. Artinya bahwa rumah sakit menjamin terjadi suatu kelangsungan alam. Kita tahu, slide. Ada beberapa di pengalaman slide. Ada suatu hal yang akan kita ungkapkan, yaitu bagaimana water management. artinya manajemen IPAL. Karena kita tahu rumah sakit adalah suatu hal yang jadi problem utama adalah bagaimana penanganan IPAL. Kemudian salah satu bagaimana kita mau melakukan energi, hemat energi, dan kemudian salah satunya adalah menciptakan rumah sakit bukan bagaimana yang ditakuti. Artinya rumah sakit tempatnya yang orang sakit yang menakutkan, tapi bagaimana kita melakukan inovasi di mana rumah sakit adalah tempat untuk healing, right? Kita tahu bahwa produk dari limbah cair rumah sakit sedemikian banyaknya, mulai dari, karena rumah sakit kami adalah rumah sakit tipe B dan sekarang menjadi rumah sakit tipe A dengan 400 tempat tidur, dimana mulai dari recek dari RO, kemudian bagaimana IPAL, semuanya tidak ada yang terbuang. Kita tahu bahwa save water artinya bagaimana menghemat air itu adalah kunci utama, karena kelangsungan daripada hidup manusia adalah salah satunya adalah air. Ini adalah kita pahami bersama inovasi-inovasi dari rumah sakit teman-teman adalah kita bagaimana fokusnya rumah sakit tidak menimbulkan banyaknya problem sampah, problem tentang air limbah yang pasti menjadi suatu hal yang menakutkan bagi masyarakat yang tahu. Kalau tidak tahu sih mungkin belum. Tapi kalau seandainya masyarakat tahu maka bisa disu, yaitu bisa istilahnya kita bisa tentang pidana lingkungan itu. Right. Rumah sakit akademi UGM adalah rumah sakit yang miliknya UGM, di mana ada beberapa fakultas sekolah vokasi. Kemudian di situ kita kerjasama bahwa gamaren namanya. Ini adalah hasil dari penelitian teman-teman dari sekolah vokasi dari UGM, di mana air hujan itu tidak terbuang percuma. Gamaren ini di mana kita juga rumah sakit mempunyai tugas salah satu manajemen, yaitu tentang mendistribusikan CSR. Kita bagaimana rumah sakit memberikan suatu CSR dalam bentuk gamaren ini di Gunung Kidul. Gunung Kidul yang kesulitan air, di mana tiap musim kemarau dia adalah suatu hal yang jadi problem masyarakat. Kita kasih itu tentang gamaren. Ini tiap tahun kita melakukan suatu CSR, right? Begitu juga kita gamaren di rumah sakit. Ini adalah tiap gedung kita berikan suatu tower, istilahnya tandon air ini seperti ini. Itu sekitar ada beberapa yang diharapkan nantinya air tidak terbuang percuma, tapi minimal untuk siram-siram untuk tanaman. Right. Nah, kita apa yang dikatakan tadi Prof. Gufron, bahwa rumah sakit, karena saya adalah termasuk pecinta olahraga yang katanya tadi untuk tetap agar bugar. Kalau Prof. Gufron adalah tenis, saya adalah goes, cycling. Tapi ada beberapa kelompok yang kita bentuk, yaitu ada sekitar 4 kalau nggak salah. Itu tiap-tiap kelompok itu setiap kali habis melakukan suatu olahraga harus satu menanam pohon, atau menebar ikan, atau melepas burung. Ini adalah kemarin, barusan kemarin itu adalah sekitar 6 dari kita olahraga gue dari Magelang sampai ke Jogja. Kemudian kita ke, ini adalah bentuk, ini di rumah sakit, kolam resapan. Kolam resapan di mana tidak ada IPAL, air limbah itu terbuang percuma. Di sini IPAL itu sebelum kita masukkan ke tanah sebagai resapan yang semuanya konsultasi dengan KLH. Itu akan kita di sini banyak ikan lelenya. Tapi nanti kalau mau kita konsumsi maka harus konsultasi dengan Fakultas Pertanian untuk apakah layak konsumsi atau tidak. Artinya, apakah kandungan merkuri atau yang lain. Ini kita melakukan kolam resapan dan filtrasi ini adalah agar apa? Air tidak semuanya terbuang percuma di sungai. Tapi tetap harus kita masukkan, tapi semuanya konsultasi dengan, dan kita kolaborasi dengan fakultas lain. Right? Ini juga untuk siram-siram. Baik. Nah, ini kita menggunakan namanya energi mikrohidro, di mana air limbah kita naikkan stepnya. Nah, kita naikkan di sini, kita masukkan di dalam turbin, kemudian masuk di dalam penyimpanan aktif. Dan ini tiap malam taman ini adalah diterangi oleh hasil mikrohidro. Ini konversi sehingga air limbah itu bukan hilang percuma, tapi kita rubah menjadi energi yang diharapkan menghemat energi. Slide. Ini adalah bagaimana prosesnya. Ini konsultasi dengan Fakultas Teknik Elektro. Hanya kita dari RSA UGM itu rumah sakit milik UGM yang selalu memberikan kolaborasi. Contoh kolaborasi antar fakultas yang menghasilkan hal-hal yang baik. Lihat. Ini ke depan, ini baru perencanaan yang masih dikonsultasikan dengan PLN, di mana nantinya seluruh atap ini akan kita kasih panel surya. Dengan harapan bisa menghemat sekitar ya 14 sampai 15%, 14 sampai 18% energi yang ada. Dengan harapan bisa menghemat biaya, yaitu sekitar kalau 1 bulan itu 1 miliar. Biaya rumah sakit 1 bulan 1 miliar untuk energi saja, maka bisa sekitar 150 juta. Dihemat. Right? Artinya sampah-sampah organik yang ada di rumah sakit tidak hilang percuma. Yaitu sampah-sampah daun-daunan kita rubah menjadi kompos, yang tadi mungkin Bapak Ibu sekalian sudah melihat di sana ada produk dari rumah sakit, kemudian pupuk organik cair, kemudian ada semuanya ini bukan untuk rumah sakit, tapi kita berikan CSR para petani, peternak, karena di situ peternak ikan butuhkan yaitu makan. Para petani dan yang lain kita butuh tentang pupuk organik cair dan juga kompos, sehingga rumah sakit akan menghidupi masyarakat sekitar. Bukan untuk rumah sakit kemudian ya bahasanya eksklusif ya, rumah sakit bisa semuanya tapi masyarakatnya hanya terdampak. Kita nggak mau. Artinya bahwa semuanya ini kita distribusikan ke masyarakat. Baik. Ini prosesnya, ya ini kita pakai karena kita sama-sama. Ya ini ada Antabuga, itu adalah dewanya bumi. Artinya kita lokal wisdom. Right? Ini kita juga menanam semuanya tanaman yang ada di rumah sakit memakai produk rumah sakit sendiri, tidak memakai bahan kimia. Bahkan kita sudah mulai melakukan penelitian dengan Fakultas Biologi. Nanti ada namanya produk dari bio, dari itu pengganti deterjen. Masih dalam penelitian karena masih tidak sebanding saat itu. Diharapkan dengan menggunakan bio ini deterjen tidak akan dipakai di rumah sakit. Right? Ini semuanya tanaman adalah menggunakan pupuk-pupuk yang kita ciptakan sendiri. Right? Ini sama, kita menggunakan pupuk organik cair yang di rumah sakit itu menjadi taman bunga ini, karena kebetulan direktur SDM kami adalah pecinta anggrek. Dia bisa memproduksi, bisa dengan teknik tertentu dan kolaborasi dengan fakultas lain. Karena di UGM ada namanya UGM Orchid ya Pak ya, yang saat itu diketuai oleh Prof. Iwan, almarhum Prof. Iwan. Artinya bahwa kita rumah sakit, sehingga kalau kita mau melihat rumah sakit tidak seperti melihat hal yang menakutkan, tapi bagaimana bisa melihat anggrek yang ada di rumah sakit, dan semuanya tanpa bahan kimia. Slide. Ini rumah makot, kemudian ini slide. Kita juga menggunakan tempat-tempat yang memang saat itu inilah di roof, di mana tempat roof ini bisa digunakan sebagai tempat relaksasi. Right. Salah satunya ini adalah healing garden, di mana pasien-pasien yang masih pakai infus itu, saya nggak kita foto, itu bisa pagi-pagi bisa berjemur. Dia menghirup udara segar, hampir melihat kolam, kemudian untuk bisa memberikan makan pada ikan, sehingga mencapai healing dengan harapan seperti itu. Bahkan burung-burung kalau pagi itu banyak sekali, dan itu adalah ternyata kami belum melakukan penelitian, masih dalam penelitian bagaimana healing ini bisa memberikan suatu wellness pada pasien-pasien yang menggunakan. Lihat, ini adalah salah satunya, kita bisa untuk melakukan kolaborasi dengan para, ini adalah UMKM, anggota UMKM yang kita kelola. Right. Anggota UMKM yang sebagaimana menggunakan produk-produk ini kita bentuk kolaborasi, yaitu pasar namanya. Untuk nutrisi ini tadi sudah ada, bagaimana produk UMKM kita kelola dengan bersama. Right. Oke, ini adalah ada pasar krem yang itu adalah market yang menampung anggota masyarakat sekitarnya, bahwa masyarakat di sekitar rumah sakit UMKM-nya PKL pedagang kaki lima, kita lakukan rekrutmen untuk bisa melakukan pasar 35 hari sekali. Dengan seperti ini adalah andalan ada jamu dan yang lain. Ini PKL atau UMKM binaan sekitar 50-an. Right. Oke. Prinsipnya ini adalah semoga menjadi inspirasi dari seluruh rumah sakit. Kalau rumah sakit tanpa mengelola seperti ini, maka rumah sakit menjadi beban. Kalau saya sebagai direktur mengatakan kalau rumah sakit tidak memperhatikan lingkungan, maka itu akan menjadi beban lingkungan. Bahkan akan menjadi suatu rumah sakit sebagai sumber penyakit dari masyarakat sekitar. Kalau tidak melakukan penanganan limbah dengan baik, lingkungan dengan baik, maka di situ karena masyarakat tidak tahu aja bahwa suatu saat kita akan sama-sama bahwa tidak akan tercapai yang disebut kesehatan untuk semua. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Terima kasih Dr. Darwito. So Dr. Darwito has shared about the innovation and also the ideas that has been implemented in the hospital, how to convert all the waste into energy, how to use the dead space even in the rooftop for healing and also for collaboration. And it's not only inward looking but also trying to engage with the community. And within this university we have a lot of schools and faculties. They are also involved in the program of the hospital. So thank you so much. Now it's time for us to discuss. I actually gather in the intersection of two most critical global issues in our time, the sustainability of our planet and also sustainability of our health system, particularly the financing system. On one side, the urgent need to protect our planet, climate change, but on the other side, we know that the Prof. Junit, Prof. Gufron, also Ibu Becky also mentioned about the challenge in the health financing. So how to link these two issues, we will discuss it in this last 10 minutes. But prior to that, I would like to invite the two professors that were with Professor Aljunied in London by that time. So I need to have a comment from Prof. Laksono, but particularly in the out-of-pocket issues, Prof. Laksono. Yes, please, the microphone, please, for Prof. Laksono. Yes.
Yeah, I think it's very interesting. And I remember when we were in Capel Street 30 years ago, and we talked about USC. Yes, but Junit is right. At that time, it was new things. But after 30 years, then we have to be very, very realistic that we cannot rely on only one source like BPJS. Indonesia is impossible to rely on BPJS. We have to think about many things. Ibu Becky is right. She is thinking about how to innovative funding, included the private health insurance. Because actually, when we look at the out-of-pocket payment, still increasing. And Ibu Becky data shows that private health insurance is only 4% of the total Indonesian expenditure of health. In Thailand, I think it's about 17%, 17%. It was discussed in Hong Kong last month. So we are very, very low in terms of private health insurance. So that's why we have to move not only to BPJS, but also to strengthen the private health insurance to reduce the out-of-pocket spending. So I think in summary, compared to 30 years ago, the current situation is much more complicated, yeah, including the heated atmosphere or the climate change is becoming more unpredictable, and now is actually we have to be in dry season, but last night or 2 days ago, it was a very, very heavy rain in Yogyakarta. So the climate is becoming not regular anymore. Okay, thank you.
Okay, thank you, Prof. Laksono. And we go to Prof. Subasit. Professor Subasit, the particular issue in unmet needs, because Professor Aljunied mentioned that the poorest in Indonesia is already subsidized, but then
missing the middle.
Yeah, in the middle. Yeah. So the unmet needs issues.
Yes. Thank you. I think the unmet need is a concept rather important and always elusive. It depends on the affordability and the context of the social at the time. So to be short, I think this will be the research questions for younger generations, as well as once we move into the forum right now, you are arranging the academic environment into the environment itself, climate change and the SDG 2030. In a few years, we will reach 2030 SDG. And think next, we would like to have the financing mechanism for the broader issues and also the unmet need, just to let the younger generation think further.
Yes. So it's our turn. Yeah, Professor Subasit mentioned that this is the turn of the younger generation to think about the more complex situation, as Prof. Laksono mentioned. So, from the floor. Questions? Yes, Professor. The microphone, please.
When we talk about universal health coverage, it has 3 dimensions. One is the package, second is the coverage, and the financial affordability. Right? Now, when you're talking about universal health and also coverage, we are not talking about what is the package each country is talking about? When you say universal health coverage, what is the coverage for universal coverage? Most of the countries has universal coverage for immunization, right? Or antenatal care. But I think whenever we are talking about financial implication and impact, we need to really talk about each country. What is the package we are talking about? In Thailand, when they wanted to have within the coverage a home-based dialysis, they had to add $2 billion. When they are talking about coverage for cancer, they needed another billions of dollars. So whenever we are talking about coverage or universal health coverage, we really need to take each country, what is the package, and which coverage will be, which population will be served first. Because diarrheal disease is for poor people. Should we cover free salt, the package, or we talk about statin for preventing the heart disease. So we need to really talk about for whom government should spend what amount of money and what is the package. Because will be a politician who will play a bigger role on this. Because me can say this should be the package, but it will be decided by the parliament, by the politician. So it's not that simple thing, what you're talking about. I think that needs to be really looked at in each country. What is the package? What is the coverage? Who should get first? And how much money we have in the country to really fulfill the coverage.
Thank you, Professor. So I go to Prof. Aljunid. So the package, because you also mentioned the limitation is the financial capacity.
Yeah.
So it will determine the package. Please, Professor Aljunid.
Yeah. I think I still want to flashback what we did in Prof. Emil's class when we were attending Health Economics 101. Yeah? The first thing that you must remember, healthcare needs is always unlimited, but resources are always limited. So we have two different scenarios, two different situations. So the best way is actually each country have to decide on the essential health services. Even within the essential health services, there are many components. We are talking about, for example, drugs. What drugs should be covered, what should not be covered. Broader perspective, curative versus preventive. Preventive should take priority. I think we have seen what are the efforts by BPJS trying to promote healthy environment and good behavior. And within the curative services, there are services that are required. So again, when we talk about essential health services, now we have a lot of young health economists that learn from us. They are now trying to define what we call the benefit package. Now remember, we cannot pay for everything. Okay, so the rule of thumb is that if it is a private goods versus public goods should be covered. Private goods should not be. But how to differentiate it will depend on the amount of resources that we have. And this is very challenging because in developing countries like us, we are spending less than 5% of GDP. Malaysia 4.75, Indonesia is about 3% of GDP. Resources are always limited. But we have to strike and try to achieve a good balance. So remember, healthcare need is always unlimited, but resources are unlimited. So we have to juggle between these two. And when you implement the program, like what Prof. Gufron's program is, he has to face all this, you know. The money given to you is limited. You know? So this is where they have to bite the bullet and make decision. Maybe home dialysis will not be covered, for example, in some country. Other countries who have got more effort, for example, they can cover that, you know. So it depends on the priority for each country. That's my take on this.
And Prof. Gufron, because you are the implementer, maybe you can describe the package that Indonesia has.
Okay, first I would like to thank to Prof. Basi. I think it is very genuine questions and comments. Of course, Prof. Supasit also Prof. Laksana. So actually in WHO there are 3 dimensions as we mentioned. So namely the benefit package, out of pocket, and how many people covered. So in Indonesia we almost all people covered, 98.7%. And then out of pocket reduced from 49.7% to 25 to 28%. And then for benefit package, as I mentioned, there are 2 things, public health and also personal health. So personal health on the demand side is the responsibility of the BPJS. So benefit package is related to the personal health on promotion, prevention, curation, or curative, and also rehabilitation. So all of that, as far as it is first medically indicated, second, according to the procedure, should be paid by BPJS. But if it is pure public health, for example, like COVID, like tuberculosis, surveillance system, and active detection, is not under BPJS. It is under Ministry of Health and under local government. So we now cover almost all personal health, but personal health only. And this should be, again, based on the medically indicated, and then second, according to the procedure. I think it's clear.
Okay, thank you so much for the explanation, Professor Gufron. So it's not only the resources that are limited, but also our time. Yeah, because the committee already gave me a sign that we should end this.
So before end, can I just read the pantun?
The pantun.
Yeah,
yes,
pantun.
Okay.
This is like the theme. Okay.
Yes.
A bird in the sky, soaring high. Universal health for all to try. No one should suffer. No one should die under the USC sky.
Yeah. Give you a big applause.
A gentle breeze through the trees for quality health. All can appear. We are in Gadjah Mada University to discuss under what university health coverage piece.
Yes.
Thank you very
so much,
much.
Prof. Gufron. So, as promised before, any one of the students can give a summary of this session, please, because I don't want to bring this back home, huh? Yes. Any of you? Yes, please. Microphone, please. In the middle. No pantun, eh?
Ada
You have enough
yang
pantun.
bisa kasih. Oh, itu.
Yeah. So please mention your name. Yes.
Okay, thank you for the opportunity, Dr. Andreas Samedara. My name is Zikri Fadila. You can call me Zek for the people side Indonesia. I'm from the Department of Health Policy and Management. So I'll try to summarize the conference today, the first session. So the first presenters, Dr. Tan Suyanti from the MOH, is highlighting the national strategy on antimicrobial resistance control in healthcare that aims to enhance the WAS with structured 5-step WAS specialty improvement tool. It's really interesting tool. And then the second one is Prof. Aljunid. Prof. Aljunid highlight the current landscape on health financing in LMIC. And him concerns about moves away from reliance on user fees and have a pool funding. I think it's multiple pool. And the third one is from Prof. Gufron, the BPJS Kesehatan, the contribute on the demand side. I think it's the most important thing I've learned today, the demand side of health services. And the model business is divided into 3, the strategic purchasing, the risk pooling, and the revenue collection. And also the highlight for payment for primary care is performance-based capitation, and in NCBGs for hospital. And Prof. Gufron also emphasized all of the awards that given to the BPJS Kesehatan, and also they have telemedicine services, which is I just know this morning, and the iCare system so that members and doctors can access the history of patient taking help across in Indonesia. And the conclusion is BPJS has successfully contributed to UHG achievement effort in Indonesia, but we still have work to do in the equity. And the fourth one is for Ms. Becky. It's a really good presentation. Ms. Becky has highlighted the total health expenditure on GDP in Indonesia is only about 2.9%, which is still very low. And the private health insurance scheme is 4.6% from the current health expenditure. And the public spending is quite high, it's 51.8%, and the out-of-pocket is 33%. And she is emphasizing health financing transformation pillars. Also, one of the main innovative financing step is measurable outcome. And I think the main reason we need to innovate in financing is to bridging the gap that we're trying to fix it. And the example is like PPP, syntaxes from alcohol, tobacco, and surgery drinks, and result-based financing. And the interesting next agenda is global budget and blended budget. And she emphasized again in focus on equity and sustainable. And the last one is Dr. Darwinto, talk about the hospital academic in UGM is really quite interesting. Talk about pathway to green hospital in Indonesia, the hospital waste management, the hospital that is friendly for all of the pillars for all the people. And the most interesting is there is try to make a circular economy with the invited entrepreneurship, small enterprise, and then from Prof. Laksono comment that we can rely on one single payer for make it realistic on government burden. And the second question from Professor is what is the package, for whom the package, and how much money we have. And Prof. Aljunied answered it that we can pay everything. It really makes sense, and resource is limited. And how to difference the public and private sector with the rational benefit package and improve one. The last one is concerning about the public health issues and personal health issues that mainly BPJS is concerning about. I think that's all, Dr.
Yes.
Andreas.
Okay, thank you so much. It's a very clear summary, and I hope he's not the secretary of this
so, but
meeting.
if
Yes.
you give, you know, the present,
Yes.
can I also give the present?
Yes. What is the present, Professor?
The books. The books.
The books. Oh,
yeah,
okay,
yeah.
okay.
And not only that, it another one. I just ask one question only, and I give. Oh, please give the book. Also give the book, another books. The question is, BPJS Kesehatan under which ministry? Yeah. Oh, great. So the correct answer, please give the. Thank you.
Yes, thank you so much for your participation in this plenary session. And of course, after this, we are going to talk about the solution that as an academia, we need to create or to develop a solution for all the challenges that has been mentioned in this session. But then again, the solution should be grounded in science, scalable in policy, and also centered on people. So we give again big applause for the speakers and for all of us. Thank you so much. I give to you, Mbak Katza.
Thank you so very much, Dr. Andreas Tameliala, and all speakers. Ladies and gentlemen, as a gesture of our gratitude, we would now like to present a token of appreciation, a souvenirs to all speakers and moderator for their valuable contributions and insightful sharing during today's session. And we kindly invite Professor Laksono Trisnantoro to present the souvenir to all speakers and moderator. The tokens of appreciation are now being presented to our speakers, such Professor Dato Dr. Syed Mohammed Aljunied, Professor of Health Economics and Policy, UKM and IMU Malaysia, and then Professor Dr. Ali Gufron Mukti, PhD, President Director of BPJS Kesehatan, and Dr. Darwito, President Director Academic Hospital of Universitas Gadjah Mada, RSA UGM, and also to our moderator, Dr. Andreas Tameliala. Please give a big applause to all speakers and moderator. Please, Professor Laksono, join the photo session together with all speakers and moderator. 3, 2, 1, capture. Thank you so very much. Thank you so very much once again to moderator, all speakers for the plenary session 1. Ladies and gentlemen, what an incredible plenary session we just had. But the excitement doesn't stop here. Coming up next, we have an important part of our agenda, which is the oral presentations. And a parallel session that will explore various themes and research topics. The parallel session will take place in 2 parts. And the part 1 immediately now, and the part 2 will continue after lunch. And the lunch is served at the auditorium lobby, and we invite all participants to enjoy the lunch that we prepare after completing the oral presentations. We inform you that the oral presentation will be held in each rooms, and the moderator will be waiting for you at registration desk. They will guide you to the oral presentation place or room. And then we inform you that after completing your oral presentation, after lunch, we kindly invite you to rejoin us for plenary session 2, which will begin at 3 p.m. here. And then for those participants who will perform to Zuhur prayer, please proceed to Masjid Ibnu Sina. Ladies and gentlemen, if you have any question regarding the schedule or the venue, please do not hesitate to contact our committee, and we are very happy to assist you. And don't forget to visit our tenant outside while you're having break or lunch together. Thank you so very much, and see you at 3 p.m. Our moderator will be waiting there and will guide you to the oral presentations room. And we once again inform to all of you that after the oral presentations, time 1, you will have lunch together, and after lunch you will continue your oral presentation in each room. And we waiting for all of you to join the next session, which is the plenary session 2, here at 3 p.m. Thank you.
We have the important discussion as we explore innovative and sustainable approaches to strengthen health system, we hope. And also, first thing first, allow me to introduce our distinguished judges. Here, first is Professor Dr. Muhammad Rizal bin Haji Abdul Manaf from the Department of Public Health Medicine, University Kebangsaan Malaysia. He is an expert in public health with key research in health economics and quality of life. And the other judges is from Dr. Dia Ayu Puspandari. She is from the Department of Health Policy and Management, and she is also the director of Center for Health Financing and Health Insurance Management, and she has extensive experience in health economics, insurance systems, and health technology assessment. So, before we begin, here is a brief overview of the session format. Each presenter will have 8 minutes to deliver their presentations, and the timer is there, followed by 2 minutes questions and answer sessions. And then the Q&A segment will not moderate it, so it's automatically after you present, and then will be the Q&A sessions. And then you will see the timer there, and we hope you manage your time and conclude your presentation promptly when the timer reaches 0, and to help us stay schedule. And also the timer will start as soon as you begin speaking. So when you begin speaking, the title or anything, we will start the timer. Okay, let us now proceed with our first presenter. It's Mr. Chandra with the presentation titled Trapped in the Menu, How the Rigidity of BOK Funding Limits Health Program Planning Based on Local Needs at the Puskesmas in Bau-Bau City. So please welcome Mas Chandra.
Yeah, good morning everyone. Ladies and gentlemen, my name is Chandra. I'm from Center for Health Policy and Management at Universitas Gadjah Mada. Today, I will present our research titled How the Rigidity of BOK Funding Limits Health Program Plan Based on Local Needs at the Puskesmas in Bau-Bau City. This study explored two critical challenges in Indonesian public health system, focusing on disconnect between central funding and local health authorities. In outline this presentation, I tried to start by background, problem statement, and research objective, methodology, key findings, discussion, and result, conclusion, and policy recommendation. So, to understand the issue, we must first look at the key players in Puskesmas. Like Puskesmas are public health center in Indonesia, are the very foundation of Indonesian primary healthcare system. They are responsible to delivering essential public health programs to directly for communities. So primary source of their funding is the Health Operational Assistance Fund, we call BOK Fund. BOK Fund provided by the central government to support preventive and promotive health services. In principle, health planning should be a bottom-up process where local needs identified through plans like the RUK, the proposed activity plan, dictate the programs. However, the central problems we investigate is the significant concept of the rigid top-down structure of BOK funding limit the ability of Puskesmas to plan programs that truly address the specific health issues in their areas. So our main objective was investigate the structural rigidity of BOK funding restrict Puskesmas in Bawah City from developing and implementing health programs that are genuinely tailored to specific local needs. To achieve this, we employed a qualitative case study design. Our research focused on 3 specific Puskesmas in Bawah City. There are Puskesmas Wajo, Puskesmas Katobengke, and Puskesmas Liabuku. We gathered data through in-depth interview with 12 key informants, including health managers and health workers in Puskesmas direct involved with BOK funds. So we then used thematic analysis to identify the core issues. Our analysis broke 6 main themes which illustrate how BOK flexibility undermines need-based planning. There are dependency on the central government's menu of programs, second limited and often mismatched budget ceilings, and third inflexible proposal processes. Fourth, a lack of local flexibility to reallocating funds, and fifth, complex regulation and rigid cost standards, and finally, funding allocation that are not based on specific regional characteristics. So let's look closer at the findings. First, Puskesmas are highly dependent on predetermined menu of program set by Minister of Health. As one informant stated, this means Puskesmas are not free to allocate the budget according to urgent needs, not included in the menu. So this immediately restricts local priorities. Second, this is made worse by mismatched budget ceilings. Puskesmas may propose activities based on local needs, but thus often cut because often final budget fixed and not negotiable. And third, the proposal process itself is a barrier. It relies on complex centralized applications that often fail to capture the reality on the ground. Fourth, there is a critical lack of flexibility. Puskesmas cannot easily to reallocate funds between menu items to respond to emergencies, like a disease outbreak without a long approval process. As another informant noted, it is difficult to defer funds if there is no special allocation for it. So the final 2 finding point to deeper systemic issue. Fifth, complex regulation with rigid, centrally determined cost standard create confusion and a fear of audit findings among Puskesmas staff. The standards often don't match the real cost in local area. Finally, the funding formula itself does not adequately account for local context. Puskesmas in area with vastly different geographies, population densities, and or disease burden often receive similar funding, which leads to significant inequities. So what is the core conflict here? Our findings show a fundamental disconnect. The system expects Puskesmas to perform bottom-up planning, yet the BOK funding mechanism operates as a rigid top-down system. To this turn local planning into a futile exercise, Puskesmas are forced to align their activities with the available funding menu rather than with the actual health needs of their communities. Most critically, effective health program planning in Bawah City, it traps Puskesmas, preventing them from optimally addressing the unique health challenges.
As a researcher, this is great because you have this beautiful natural experiment with all these different variations of health insurance schemes in a country where you can see what's going on. And it wasn't just great for the researchers, it also worked really well for some of the Bupatis who managed to get elected. And that was a great inspiration for Jokowi, who then thought, well, actually, if I promise this to my entire population, maybe I can get elected. So offering health coverage became a political asset. He got elected, and the drive towards universal health coverage really got going in Indonesia. And we analyzed that and traced that back, how that got. And this is until 2015, and we now know that about 96% or 97% of the country is covered by universal health coverage, at least in terms of having health insurance. Because this led to our next paper, and there was a study led by Pratiwi, and she looked at whether or not the people who have health insurance also actually can access health services, because it's great to have an insurance card, but you need a little bit more than that. Maybe could I just say next slide to somebody? Because so that was our next question. Indonesia has a very generous benefit package, but you can offer open heart surgery to everybody, but other services there, especially in such a huge country. So we start to analyze this. And this is what we found. You see, this is a study whereby they used the PODES data. The village heads were asked, how good is your access to healthcare? And you see that in Java, Bali area, it looks really good, but you see in a large part of the country, the healthcare access, the access to health services is still a big challenge. So this is a big part of the drive towards UHC is to solve this. And I think everybody in the room knows this. So somehow you need to, the big challenge for Indonesia is on the one hand to scale up the health system, scale up services to all these remote, more remote areas. But also, if you do so, how do you keep the system affordable? Because if everybody starts to consume the same healthcare as Java does, it's impossible to pay for. So a lot of things need to happen there. There's a lot of strategic decision making it needs to do. And so what did the government do? One of the things that the government did was, okay, so can we try to reduce cost? And they've been very, very effective in one field, and that is the cost of medicine. They reformed procurement policies and managed to bring down the cost of most essential medicine by more than 50%. And that was very interesting because the response from industry was, of course, well, this is unsustainable. You can't push prices down so much. This will lead to very poor quality. And the government kept on banging on the door, saying, no, those prices are still too high. So the question was, who's right? Do those low prices actually lead to poor quality medicine? And it wasn't just the industry that was concerned about those low prices. It was also people in the general public, everyday Indonesians. And there were two things going on. One is, on the one hand, doctors and pharmacists were pushing patients to pay for more expensive medicine. But also, at the same time, there were several scandals with poor quality medicine. We had the big fake vaccine scandal several years ago, but also the scandal with lethal cough syrups that killed several people. And Amalia Hasnida, who's sitting over there, wrote a great paper about these different dynamics and how that also shaped then this perception about the relation between price and quality. So then Amalia and other Indonesian researchers said, okay, let's put this to the test. Let's analyze to what extent actually there is a relation between price and quality. Do those more expensive medicine, are they better than the very cheap ones, the unbranded ones? So the study was set up, and together with several other researchers and people who are in the room, like Embus, who helped with great data collection in Kupang and other areas, they started to do a study whereby they sampled they went to more than 500 pharmacies. Or not just pharmacies, but also to toko obat, and also to midwives selling medicine, to sample amoxicillin. And there's a lot of variations in amoxicillin on the market. Altogether, about, I think, 189 different variations, so different brands. So they want to figure out, okay, are those more expensive brands better than the cheaper ones? Is there a trick? So they sampled in different parts of the country. The Jakarta area, they sampled in the area around Malang and also in the area around Kupang. And what did they find? There's the Jakarta area, east and the East Nusa Jakarta. What did they find? Well, they found about 12.5% of the antibiotics were out of specification. So there is a problem with poor quality medicine in the country. This amounts to about 50 million doses a year. So there is an issue here. But then the important question for us was, is there a relation between the price and quality of medicine? So are the more expensive variations of amoxicillin better than the cheap ones? Amalia did a very good analysis. There was absolutely zero relation. So some people pay 10 times as much for a very nice looking branded amoxicillin, and other people get very cheap generic ones. There is no relation between the price and quality of the products. And that inspired the biggest study called the StarMeds project, which did something similar for 5 different medicines, and also found a bit lower prevalence of poor quality, but also no relation between the price and quality of medicine. So we have 2 large studies looking at several different products, I think altogether about 1,500 samples, showing there's no relation between the price and quality, and the government can push down those prices, right? So that's great news for the government. But still, a lot of people remain concerned about this relation between price and quality. They remain concerned about what was going on. So we said, okay, let's do a systematic review of the literature, and let's see what is known internationally from all other countries in the world about the relation between the price and quality of medicine. Are more expensive medicine any better? And you know, a systematic review is a lot of work. Some of you have probably done it. It's one of the most awful things to do as a researcher, because you spend endless amount of time going through papers. So I was talking with my students about it, and they said, well, that takes forever. Can we not just use AI? So I said, well, it's actually quite interesting. So let's compare. So let's do a traditional systematic review and see which papers are included. And let's also use AI to do the same review and see what comes out. And there's all kinds of different AI tools. And some are for free, and some you have to pay for. And some say, we really are very good in scientific things, and others say, well, we'll just give more general questions. So I assigned my students all different groups. Some of them were in the room, and they did this analysis. And I was very curious to see, okay, do they come up with a similar answer? And especially, what kind of sources does AI use? Which publications that should be in the article are actually in the article?
Your time's up, so maybe you can quickly summarize.
So let me go to my, so there's basically, I will go back one. Basically, very quickly, there's 20 papers that should be in the analysis, according to the traditional systematic review. That's the one on the left. All the other ones are AI tools. And you see that if you look at the green, the papers that should be in the systematic review, most of them are not, they are missing. And instead, these AI tools, all of them use a whole bunch of scientific publications that are completely irrelevant. Some of them were even about the quality of hotels. So, be careful with AI. To conclude, the good news is that low-cost medicine are just as good as more expensive ones, right? So that's very good news for the government. And that's essential for making universal health coverage in this country affordable and to provide all Indonesians with medicine that work. So how about the use of AI? Well, some tools gave the correct answer, but many of them used irrelevant publications. So for the new generation of researchers, let's see how we can use this properly, but be careful when you do a systematic review. Thank you very much.
Thank you, Dr. Martin. Please give a big applause for him. Okay, so the next speaker, Professor Qazi Monedul Islam, will share about challenges and priorities of public health in 21st century. Please, the floor is yours. You have the pointer here, and if you feel any lag, you can just say
next. Good afternoon. We all public health people need to ask ourselves what we are doing so far. Should we continue doing the same thing? Or we need to think whether there are changes, transition happening, and ask ourselves whether our health system is ready to cope with those changes. Unless otherwise we understand those issues, because we will be doing the same thing, we will not be able to change. Whether the financing is all right, whether the coverage is all right, or the areas what we are dealing with are okay or not. So I will take you through some transition and then ask yourself, is our health system is ready to cope with those changes? Next slide, please. So I will talk about the epidemiological transition, demographic transition, migration, climate change, emerging disease, digital transformation, antimicrobial resistance, unfinished agenda, and last of all, politics of health. I believe all public health people needs to understand. You don't need to be a politician, but why not? But you need to understand politics of health. Okay, so what we have seen so far before, there is a transition happening because we had all those communicable diseases like TB, malaria, HIV. Now, except in Southeast Asia region, we have only India and Indonesia and some in Myanmar. TB is still very prevalent and it's a priority, but malaria is almost not there, right, it's going away. And HIV has become a chronic disease. If you have got HIV, you no more a death sentence. You can get the treatment and survive longer. And although HIV is going up because of the culture, our behavior pattern changing, right? Because we are not seeing anybody dying, we said, oh, nothing will happen, we can continue to the same sexual behavior. So HIV is coming up. But anyway, there is a transition happening to non-communicable disease because of our behavioral changes, because of how we are leading our life. 65 to 70% of the death nowadays, according to WHO, are because of non-communicable disease. Now, non-communicable disease is preventable if we really take action on the right time. If we change our behavior, food habit, and also do some exercise, another thing. So we need to really look at, are we ready? Because this will be very expensive. Think about somebody getting a diabetes at age of 30 and life expectancies has gone up, going into 70 or 80, 40 years you have to take the medicine. Can country afford that one? Right? Is our health system is ready for that? Or should we have primary health care dealing with this? Or secondary or tertiary care should deal with that? Whether prevention should be the better or the cure should be, or we should be both. Our healthcare providers are ready for that. Do I have enough cardiologists? Do I have another diabetes, the specialist in diabetes? Or primary healthcare people can do that thing. Or whether, like in Indonesia, you have introduced birthday. That means every year you have to come for medical checkup. Whether we should also start the same thing, an early detection of the disease, right? So that we do not get into somebody getting diabetes or heart disease and becoming more expensive. Then there is the demographic transition happening. Except India and Indonesia, fertility has gone down. Bangladesh, few years ago, fertility was 6, total fertility. Now it has come 1.9. That means we say if it is below 2, that means your population is not growing, it's going down, okay? In our Southeast Asia, it's only Indonesia and India. It's still fertility is higher, population is growing. So, and then life expectancy has gone up. People are living longer, but they are not really providing economic benefit. because then the dependency ratio, if you know the dependency ratio, is increasing. Can our country afford this elderly care? It should be a home-based care, or it should be a facility-based care? Or it should be a primary health care, or it should be expensive tertiary care? We need to decide about those things, right? So this transition we need to. But then, like in Indonesia, India, Bangladesh, there is a huge number of young people. Now, how do we keep them alive and healthy? So that we need to also, it's a prevention or treatment, what we need to do to keep, so that become productive. On the other side, this population is going down, but there is still there is a young population, right? How do we get demographic dividend? How do we benefit keeping our young people to make sure they don't get disease, right? Those are the things we need to look at. And if it still grows, then food security. If I will come back to the climate change happen, food is not growing, and then we need more food, and then can the country keep the food security and nutritional problem? So we need to look at all those issues. Net migration. We always talk about our migrant worker and people from Indonesia going outside, but we don't talk about internal migration. Urbanization is becoming a huge problem. Now, in many countries, you look at urban health is not within the Ministry of Health, it's within the Ministry of Local Governments, like in Bangladesh. And it's run by the NGOs, right? And there is no communication between these two. So what happened if the internal, migration happened and urbanization happened? I've been to China. I've been to the village. What do I see? Old people living in the village. All young people are in the cities, right? How do we tackle urban health? Is becoming a huge problem. Slum population. How do we provide services to them? And if infectious disease come in, and that can be a huge issue. I will come back to that one. And then we have external migration. A lot of Indonesian people, Bangladeshi people, Thai, or say Indian, they are going outside, like Middle East and nothing. But they do not have healthcare coverage. If they're found to be TB, immediately they're sent back. Now, is our country ready to accept those people and provide those training? Because they are our economic driver, these migrant workers, right? How do we keep them healthy? Is our health system is ready to cope with these changes, right? So we need to look at migration, internal migration, external migration, and then the problem, war is happening everywhere. People are moving from one place to another place. We talk about migration, but I talk about people on movement. A pregnant woman, bomb happened here, and she has to go to somewhere else, and then what happened to her pregnancy and deliveries? What is happening in Gaza? I don't want to go into politics, right? So these are another issues we need to look at when people are in movement because of this insecurity and also all the war and devastation, how we are going to cope with those, the extra burden we are going to have. Then climate change. Climate change, whether we like it or not, is there. And climate change is going to affect more elderly people, according to WHO, and pregnant women and children. These are the people. Now, climate change will have food insecurity. If there is a more flood, more drought, food insecurity will come. Now, how we are going to feed your people, and they say the nutritional status, you do not have nutritional degradation, right? How we are going to cope with? And if they do not have, and they go to the fast food and all sort of thing, then you have NCDs, right? Now, then we need to look at if there is a flood and somebody is having insulin, how she is going to or he is going to get insulin? How we are going to provide that services to them so they don't die? So is our health system is ready for that? Okay? And climate change, do you know how we talk about plane and car and everything is causing greenhouse effect? Do you know what health system is contributing to the climate change? According to the study, 13%. Health. How many Have you seen big hospital? All the freezes, all the wastage, and then dumping all sort of issues, right? And then there is how many hospitals have solar power or wind power? How many people are not using reusable rather than wasting, right? So the health system also need to look at how we can become climate resilient system. Just not telling that don't fly anymore, and we help people are saying that we are not doing anything else. So climate change will have impact on your health, and also health system can make some changes to reduce the climate change effect. Then comes emerging disease. Believe me, not a single country in the world, rich or poor, were not ready for COVID. Not a single country. Every country, health system was not ready. So then we need to ask, is the COVID the last one, or there will be more COVID coming in? Definitely, there will be. Now, Ebola, Dr. Peter Piot, when he's from Belgium, when he was young, he found Ebola in the Congo area, right? But the Ebola used to be within a small area in the forest, and they would have Ebola, high mortality rate, they will die, and it will spread. But then, Ebola became a general feature. Why? The human being are encroaching to the animal kingdom, right? Today, monkey in Congo is a delicious food. It's there as a goat. Some people are having them as a pet, right? Bat soup is become a delicacy, right? You go to the city, you get the bat soup. So this is not going to be the end. We are going to have more. And then COVID has taught us one thing. We, healthcare providers, talked about saving lives from the disease. But the politicians were looking at saving life from livelihood because of the lockdown and everything, right? So how the healthcare providers can talk to the politician to come to a win-win situation, right? When WHO requested a lockdown, they talked about, because no country was ready, so they said 2 weeks time so that you can really take action to make sure that you can tackle this disease. But what happened? This lockdown went on, and a lot of people, poor people, didn't have anything to really survive. Have you seen how lockdown in Bangladesh? The disease was in Dhaka, and they have lockdown. Everybody went to the village. So what happened? Disease went from the district or the capital city to the village. Have you seen in India what happened? So we need to ask, the COVID is not the last one. Is our health system is ready? Okay, I have to finish quickly.
You have 2 more minutes.
Digital. Whether you like it or not, digital is there, right? And we need to see how our healthcare system is coping with the digital. I'm not talking about only AI, but all the, you have seen that insurance, how they're using the digital transform and providing information, right? People knows more than you when they come for healthcare. Then antibiotic resistance. We talked about the antibiotic resistance. Are we ready? Before, when penicillin came in, it cured everything. Today, ceftriaxone and higher drug is not doing anything, right? And we are talking about superbug. Is the healthcare system is ready? Can we provide, and if there is a multi-drug resistant TB, can we really cope with that? Normal TB, it can cost, say, $100, but a multi-drug resistant will cost $1,000. Who is going to provide that extra cost, and whether the health system is ready to cope with it? Then unfinished agenda. Still child mortality, maternal mortality still remain in Indonesia, in India, Bangladesh, Southeast Asia regional. Are we really, what we are doing to make sure women, because for me, no woman should die, give their life, bringing life. If a woman tomorrow says, we don't want to be pregnant anymore, human race will go away. And there will be no maternal mortality. I can assure you 1 year, if the woman says today, we are not going to be pregnant, next year, there will be no maternal mortality. But we are not doing anything for the woman to really, what they deserve, right? And the politics of health, whether we like it or not. Health is becoming a political issue. Today, you and me can decide what needs to be done, but the politician will tell what it will be done. Because we can recommend, but the politician will make it happen. So we really need to understand. I have 3 days course. I ran 3 days course on politics of health, because there are a lot of issues. When tobacco treaty came in, tobacco treaty, do you know how long it took WHO? 5 years. Today, Trump doesn't get elected without big companies pay him billions of dollars for election. Okay? Look at also in the Netherlands, the farmers group, they also are coming back. So we need to understand the politics of health, because unless otherwise politicians, we do not understand the politics of health, we will be failure. We will recommend, they will not listen to us. So we need to have a language of political language and come out with a win-win situation. I hope I have given you enough idea to think about. I'm not saying I have all the solution, but think, all those transition happening, are we ready? Is health system what we are running, are we ready to cope with this incoming transition? Thank you very much.
Okay, thank you. Applause for Professor Kwazi. And our next speaker, I would like to invite Professor Tuti. Professor Tuti will share about the resilience in the health system, why sustainable financing must include dental care. The floor is yours. Yeah,
got it.
You can use the pointer. If it's like, you can hold it over there.
Here?
Yeah, to the back, because the screen, yeah, the bubble is
Oh,
in the back.
okay.
Yeah, yeah. Maybe to the dental work, yes.
All right. Let me try. Is this one? Okay, I think I might just say next. Oh, it worked. Anyway, all right. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. My name is Tuti, and I'm also one of the PGF alumni. My supervisor is here, Professor Said, my PhD supervisor, and Professor Supasit, who actually checked my, at some time, my thesis or something, must have. So anyway, I'm happy to be here, and finally I brought up enough courage to speak at PGF, and today I bring the agenda for dental health. Yeah? And the question that I put today is why we need to include dental care for a health system to be sustainable. So that is the question. Okay. I took 1 minute for that. Next, please. Okay, just sharing a little bit about the burden of oral health problems. Maybe not many of us know that actually almost 50% of the world's population suffer from some form of oral diseases. When we say 2.5 billion people have dental decay, we're saying that we're talking about untreated dental decay. Dental decay or caries is actually experienced by about 9 out of 10. So hands up if you have never had dental decay. So never mind if you have, so you're in the majority. And 1 billion people have severe gum disease. 9 out of 10 have some form of gum disease, but 1 billion have severe. That could actually affect their quality of life. That could also actually lead to complete tooth loss, which affects 350 million people. And of course, we have also oral cancer. Next, please. So I plan to talk about these 4 items, but I think I will focus more on the oral health component because the stuff about healthcare systems and talking about UHC and resilient health systems have been covered quite a bit for the whole day. So I'll be actually talking about more of the problem that we face, especially with regards to population access to dental care. And that is the answer actually, no health without oral health. I think that was Bangkok Declaration sometime last year. that puts our health on the agenda. Next, please. Okay, so recognizing that global public health importance of major oral diseases and conditions, the World Health Assembly had actually adopted a resolution on oral health requesting that oral health be embedded within the NCD and UHC agenda. And this was reinforced in 2023 Global Oral Health Status Report to have an urgent call that oral health should be in national health strategies, financing frameworks, and primary care models. Next, please. And FDI, or rather the World Dental Federation, also supports this. And they have emphasized also that oral health must be fully financed, embedded in primary care, and governed with accountability. Next, please. So let's talk about the problem. And I think this morning there was a conversation about the missing middle. And dental health can be considered as the missing middle in two aspects. So in the first aspect is that dental care is seen as, it doesn't seem to be seen as an emergency or require urgent care as the medical care that needs to be prioritized. And on one hand, with regards to public health, sometimes dental care is not also seen as important enough that it requires enough finance for prevention measures. So it's not really prioritized, and it's not also in the public health. And because of that, we can actually see around the world that oral health is chronically underfunded, despite the massive global disease burden that we have talked about. And until today, and from the beginning of time, I guess, and until today, out-of-pocket costs still dominate for dental health, and access remains very skewed. And oral diseases is still excluded from most of the NCD strategies around the world. Next slide. And the other aspect that dental care is the missing middle is when we look at the population access or the attitude towards dental care, there is systemic neglect of our health within the broader framework of healthcare. For the population, they themselves, and talking about behavior, when dental care is not seen to be, it's too preventive to be considered as urgent. Like it can wait. If you have pain, you're not gonna die. You can still eat, although you change your diet, but it's not really urgent, But it can be very expensive. Like if you go and see the dentist, I'm sure you have had to pay a lot of money if you're paying out of pocket. So it can be really expensive when you have to do a root canal treatment, for example. And you wouldn't want to go back to see the dentist so routine because you're still recovering from your out of pocket. And it can also, for the patient, for the community, they can look at dental health sometimes because of the structure in the health system, that dental is separate from the other health problems that is not seen to be integrated. So the exclusion of dental care increases suffering that can be prevented, and it increases the downstream health costs. And it's not just dental, it can affect other aspects of health as well. Next slide, please. So let's look at the economics part of dental health. Next slide. This is the latest report looking at the global cost of oral diseases in 2019, which is huge. $387 billion in direct dental expenditures, and the rest in productivity losses, when you have pain and you can't go to work. And high-income countries spend an average of $260 per capita compared to just less than $1 in low-income countries. So what this means is that the 87% of global dental expenditures actually benefit 22% of the population, which means to say that those who are actually needing the care but cannot afford dental care is not actually getting the care. Next slide. However, we know that dental problems is actually preventable. And studies have shown that when you integrate preventive dental services with broader health interventions, it can actually reduce total healthcare spending. And there are some studies that have looked into this. Next slide. And these are some examples of the cost-saving potential of dental care. Yeah, for example, let's look at the children on Medicaid. When they are being covered under Medicaid, there is prevention of early childhood cavities. This can actually save the cost for a year. And for diabetic adults, they can actually have fewer complications and lower inpatient costs when the dental care is integrated into the system. And there are some other examples as well. Next slide. The third point that I'd like to share here is that poor oral health is actually linked to systemic diseases. So when there is poor health, it can actually lead to more acute medical episodes. Again, higher downstream healthcare costs that needs to be undertaken for curative and poorer overall health outcomes. So investing in oral health actually strengthens health system resilience and equity. So these are some studies that looks at examples that dental and health systemic health can be linked. We know that there are studies that links diabetes and gum disease or periodontal disease bilaterally, and there are cases whereby when you have poor oral health, it can actually make things. It makes your health actually a lot worse when you can't eat well, yeah, and you can't you can't actually enjoy quality of life. Okay. Okay, next slide. So the status quo is some of the ways that dental care had been financed, and perhaps as Prof. Islam mentioned just now, we could look at the way we are doing things. Is it actually working? We also heard people talk about innovative financing just now, and these are some of the ways that financing models in dental care could actually be explored and improved. So I won't really be talking about much of this. Okay? So we know now that oral health is critical, but it is sometimes neglected in the pillar of health systems. And we need to look into strategic integration through policy and financing that perhaps that can lead to more resilient, equitable, and efficient systems. Let's look at some examples of how we could bridge the gap. So here are some 4 priority actions that could integrate oral health into broader health systems and achieve the UHC goals. Number 1, to integrate oral health into UHC, to prioritize prevention, reorient health systems towards PHC, and build monitoring systems on how we can, to make sure that what we're doing is getting the outcome or the output that we want. Next. Here are some upcountry innovations that have integrated dental care into health systems. Next. This is the Malaysian patient-centered care using advanced technologies and patient-centered.
You have 2 more minutes, excuse me.
To improve the collaboration. Poor oral health is a risk for NCDs, so health systems can be optimized and strengthened by integrating oral health promotion and oral health care services for all. Good oral health can positively impact NCD treatment outcomes, so there is need to invest in multidisciplinary research and interprofessional collaboration across care teams. And finally, engaging people living with oral diseases communities are one of the things that need to be done as well. Okay. So these are the key takeaways. Oral health is essential to overall health. Financing is foundational for integration, and resilient systems must include dental care. Thank you for your attention.
Thank you. Applause for Prof. Tuti. Thank you for very exact time. Excuse me, I'm going to fix this one. I have an interesting story about oral health. So when I did my PhD in Australia, I live in the rural areas, and we have to take trains around 2 hours from cities to rural areas. And as we move from urban to rural, we've seen that the teeth of the people is getting, I don't know, getting worse maybe. Yeah. So as much as I get to the more rural areas, the teeth has more problems. So yeah, and it's in Australia. Thank you very much, Prof. Tuti. And now our next presenter is Prof. Tipawan. She will share about communication strategies and community engagement for sustainable healthcare. Please, big applause for Prof. Tipawan. Okay. So it's Prof. Tipawan, so the other one. Okay, apologies for the inconvenience. Let's wait for another minute for our technical team to start. So Prof. Tipawan is not only working as an epidemiologist, but she's also focused more about the maternal health because she's an OBGYN herself. And I believe she has seen how strategies to communicate about health messages and how to engage community for sustainable care. Like in Indonesia, in Indonesia itself, the services for maternal and maternal and neonatal health more or less rely on the strength of the community health workers. So it is expected that community health workers is engaged to provide health promotion, and also and now their role is much expected more, Prof. Tipawan. So. Yeah, the community is requested to involve directly. Yes, I think that's the right PowerPoint. Okay, as mentioned before, so if the pointer doesn't work, please just say next so the team can do the change. Yeah.
Can you make the Zoom, the full screen?
I think this, okay.
Yeah, they can make full screen.
Dibuat full screen, Mbak Mas, ini filenya apa ya? Ini PDF ya? Did you say?
Okay, yes, thank you.
Yep.
Okay, so now I will move to closer because now before this we also go to the AI, right? And then go to the global health issue. And now we come back to our zone that we will talk about the communication strategy because we need to say whether that how we can make use of the evidence that we have, right? Next. Before talking, I would like to declare the no conflict of interest. Next. So before we will talk about the communication strategy and the communities, we need to have there something in common of the definition that when we talk about the community, it doesn't mean that we need to go to the village. We do not need only go to the community, but even we are in this room, we are also in the same community because we have the same perspective and we know the way where we want to go, right? And also sometimes when we talk about the communities, they also focus on the geography, that you stay in the same place, or also that related to the group of the people. So it means that wherever or whatever we have shared common of interest. And also that when we talk about the community, thing will not be happen if we alone, right? We usually say that if you have only one stick, it's easily to broken. But you will have many, it's difficult to break. So it means that the participation is very important. And also that whatever that we want to go, we need to have the key message that we have the same understanding. Same as oral health, we need to say that what the oral health that we would like to achieve. So it means that when we communicate, we need material, we have the message, and we need to have the receiver, that how we can get the message. And we need to understand the need of community. Because sometimes we are the researcher, or when we the teacher, we don't know whether that the student want. Right? And when we do the research, we want to get something. We did not look at the perspective of the one who received our message. So it means that when we talk about the communication, it's two-way communication, it's not the one way. That is why that we need to know what is the need of the people. We need to know what is existing resources, and we need to know about the community member consensus. That is why that we need to know what we want to do. And we know about the basics. Usually that when we go to the community, we just thinking that doing something at once and then we left. Is not sustained. So it means that when we want to do something, we need to have the continuations. That is mine, that is now we talk about continuum of cares, right? So it means that we cannot stop, we need to do continue, right? Right, our postgrad forum, we not only one and stop, and now we have 19 and next year 20. It means that we need time and we need to continue doing this. And also if we look at this one, even we have the community, we know the people who have the same interest, but we don't know who should be involved. It's not easy to work it done. So it means that we need to know about the stakeholder. Whenever we want to do anything, we need to know who are involved. So stakeholder identifications and involvement is very important, that we need to improve the health outcome of the communities. And also the last bullet that I would like to emphasize, that if we know about that one, is still not enough. So we need to have the community engagement, so we can make the decision and we can make the success of implementation. Yeah, next. I don't know whether that in this room anyone familiar with WHO Interactive Evidence to Decisions, or IETD. Anyone, raise hand? Anyone familiar with this one? Not yet. Okay, it's good. So I can talk, right? So this one is called about that. If you have the evidence, we know that we want to make evidence to be practiced or to policy. But we don't know, right? Whether that the evidence is good or it can make you to the policy. So the WHO have the criteria that we can use. This one consists of 13 criteria. You can see that the first bullet, quite very important to our forum. They mention on policy importance. Because this one is mean that we want to bring evidence into decision. So the policy maker is very important. So they put the policy importance to be the first bullet. That we need to think whether that is a priority, that the policy need to be implemented. And for the second one, you see that is related to the evidence, right? Whether that if you want to put some intervention, if you talk about the vaccine, right? Vaccination, they will say, okay, what is the efficacy of the vaccine, right? We need to say whether that it's desirable effects. But you can see the next bullet, undesirable effects. How they have the adverse events, how the side effects, how they are acceptable to the undesirable effects, right? The next bullet is certainty of evidence. I think that the room in this room also familiar with systematic review, because we consider that if we got the evidence of systematic review and meta-analysis, it will be the first level of evidence, right? So we can see about the certainty of evidence, whether that is high certainty That is mean that whatever the research or the evidence come, we not change. So we will bring that to be the high certainty of evidence. Next bullet is depend on the values, how we can give the value on this intervention. And then balance of the effects. If we know about desirable, undesirable, how a balance about that one, right? How we acceptable or slightly side effects, but it's really helpful. So we need to wait. And also that different people may be weighed differently. One maybe say, okay, this one is help more than harm. Another one will say, no, this is harm more than help for me, right? So we have the different perspective. Next, about generalizability. It means that if we have this intervention, it's good. In this community, it will be okay, it's good. But when we want to implement in another community, how the people think, they may not exactly the same. However, we want to get the same generalizability because we want to see whether that intervention is really powerful. And you move to the next, another box, you think you can see that it's more related to resources. After we see about the policy, we see about the desirable, undesirable, and about the effects, you can see that how about the resource, right? If we say that, oh, it's very good, but it's expensive equipment, and it's not easy to buy, so it's not useful. So the resource requirement, and also about the certainty of evidence of the resources also important, right? We need to invest that resource or not, right? And then next is cost effectiveness, right? After we consider about the cost, we concern about cost effectiveness. And then next issue, equity. I think that when we talk about universal health coverage, we need to talk about equity issue, right? And also acceptability and feasibility, how is accept in communities and also is feasible or not. Even accept but it's not feasible, it cannot be. This one is a 13 criteria of the WHO interactive evidence to decision. So next. For that one, we find the paper that they tell about how the WHO have get those criteria. And you will see that they also show that the first one, before you set up this criteria, is come from what is the problem identification. After get that one, we need to formulate the question. I think that we are also familiar with the PICO, right? First, we need to identify the population, what the intervention that we are interested, what is the comparison, and what is the outcome that we are concerned. After that, we need to see on each criteria, and we see whether that how it look like. You can see that on the last one. It depends on the people who will make use of this one. If we are the commission, we cannot go depth into policy or making implementation. We are recommended, right? But for the one who make close to implementation, they need to decide and make the decision. Next. And also that whatever we think that, okay, when we evaluate that this intervention is good, it should be go to decision. We need to think like giver and receiver. And mean that we are the health provider and health system. We would like the people get this, community get this, but they will say no. Don't take this to my community, right? So we need to think about both sides. This one is called social behavior change communication. So I think that all of you have know about the abbreviation of SBCC. Because when we work in the community, we use this one. And also that they use the basic socio-ecological model. You can see that the center of this model is maybe cell. So when we decide, when we see the people, the cell of the people is important. However, we have the relationship with friend and family member, right? So it means still have the interpersonal. And then we live in the community, we still have the organization service still involved. And then next is mean that environment. So this one we cannot differentiate because it's integrate each other, we cannot say. And then you can see that on this one we still have the issue of cost cutting factor that also related to our knowledge, our awareness, attitude and belief. And today I think that many oral presentation also concern on the knowledge, belief and attitude because it's a component that we involve our work more with the community. So slide next. So this one give you example that if we would like to make the sustainable for the working with community, and we need to have a good communication. First of all, we need to identify what the communication or the opportunity that we can work with the local people and the stakeholders. And also this one tell you about the step that can be done. Slide next. This one give you example that how we can use the visual interactive evidence to decision into our study to work in the community. This one the example of the PhD student in Bangladesh. He looked at the evaluation of intervention to improve vaccination coverage among the children aged 12 to 23 months. And we conduct a cross-sectional study in 6 slums, and we have demand side and supply side, both sides. Have you seen that? And we use this criteria. Next. What we found that we give you that for that certain criteria is subjective judgment. So we modify adding the quantitative. So we scoring and we use the techniques of analysis, and you can see that if you look at the first column, it means that overall we did not differentiate whether that's supply or demand side. You can see that even length on intervention is mean that education. So it means if we did not consider demand or supply, we say, oh, we need to give education to community people to improve the vaccine, right? But if you look at the second or the last column, we stratify based on demand side and supply side. You can see that perspective of the supply and demand side is different. If we look at the differentiate demand side concern on incentive, it means that they have the problem of indirect cost. They need money to get vaccine, right? But if we look at the provider or supply side, they're more concerned on multi-component. It means that just only one intervention not sufficient. So they think that multi-component much more important to improve the coverage. You can see that both sides, they have different perspectives. So we need to understand about the stakeholder to implement the intervention. So next slide. And also this gives you the example of the another study that we conduct in the southernmost of Thailand. We use the SBCC to see how the people consider on the get vaccine, because you know that even COVID vaccine now endemics, right? However, we still think whether that we need annual vaccination similar to the influenza vaccine or not. So this study we have conduct to see whether that the stakeholder consider whether that we still need it or not. And then we use the stakeholder participation, we use PAR approach, and we get the activity that how we can improve the coverage, not only COVID, but implemented to all vaccine. Slide next. What we get, you can see that based on the working with the stakeholder, we get 10 activities that the people in community think. When we say people in community, it's both the people and also the provider side. You can see that after they propose 10 activities that can improve the vaccine coverage, I also ask them whether that acceptance, practicability, and also sustainability. You can see that different activity will have different ranking. Next. Yeah, conclusions that from my talk for this one, I would like to give you the key message that the visual interactive evidence to decision is one of the tools that we can use to guide us to make objective judgment whether that we can bring the evidence into the decision. And also that if we think intervention is good, we need to think that how we can make the intervention really used in the community. And also that when used, we need to have sustain, not just only one and done. So continuation or continuum of care is very important. Thank you very much for your
Thank
attention.
you very much, Prof. Tipawan. Big applause for Prof. Tipawan. This is an interesting example of how we as academics and researchers can make the evidence more using this interactive criteria, so to make sure that community more engaged to what we are proposing. And before we have Professor Kwazi sharing about lower fertility rate and higher life expectancy. That means we have a very, very high aging population. So next, last but not least, Associate Professor Dr. Muhammad Fairuz Ali will share about how is the optimizing preventive care for older patients at primary care. Big applause for Prof. Fairuz Ali.
Thank you so much, Mr. Chairman. It's very difficult having the last one to speak. Hope you can stay awake. Okay, sorry, can you hear me clearly? Yeah? So I'm today presenting on a topic of UHC for aging population, optimizing preventive care for older patients at primary care. So it's coming from a clinical or clinician's point of view. I don't have any public health credentials, so my slides or presentations today don't have that many numbers or charts. Hope you don't mind. Okay, next. So we know that the world is aging. Yeah? We have the aging populations because of the increased life expectancy and the advancements of medicine. And in 2004, there will be 771 million people aged 65 years and older. And this number will increase definitely. And we see that in Asia and also the low and middle income country, we age faster compared to the Western countries. And because this will have very serious implications to our public health systems, not even only health, but also economics, social welfare, and others. So it increased the burden to healthcare system in achieving the universal health coverage. Okay, next. Next, okay. So even Professor Islam in his presentation asked about whether our country is ready to face this aging population. And I think these are signs of countries where, you know, if the headlines of problems regarding an aging population are all in the media headlines, we know that we are not ready. So things like financial security, placements, you know, failing to treat or manage chronic diseases. These are all things that evidence of a country which are not ready. Okay, next. So primary health care, according to the WHO, is a cornerstone of universal health care. And you can see that our policies are aligned to the primary health care, the UHC's model, where all individuals receive and needed quality health services, not only have better access, but have quality health services without any financial hardship. And these are aligned to the SDG goal of 3.8, where there are 3 pillars, which is accessibility, quality, and financial protection. And according to WONCA, which is the World Organization of Family Doctors, and I think Prof. Usni is one of the ex-presidents of one of the chapters, says that the primary health care is essential and affordable care that is accessible to everyone. So it needs to be accessible, and it has to be comprehensive, which include health promotion, disease prevention, and health maintenance. Okay, next. And for that reason, the primary care healthcare system needs to be strengthened. And these are agreed by the WHO, and also by encouraging or recommending that adding 1% of the GDP to improve the primary healthcare system. And also the 30 by 2030 campaign, where family health physicians organizations around the world has tried to improve investments from big companies like drug companies to invest more in primary care levels rather than a vertical top-down approach. Okay, so next. But the thing is, when you manage health, older adults, especially in the community, there's lots of challenges. Yeah, and you can see that we're not dealing with one or two common chronic diseases like diabetes or hypertension. We're dealing with people having multi-morbidities, and they have, next, okay, thanks. They have, emotions, they have mental health problems and high risk of getting cancers, and we are also looking into productivity, and this to do with their high frailty and also falls. And in primary care, we have this psychosocial approach where, it's not only about physical problems, but also psychosocial problems as well. And you can see that there's lots of diseases when we're dealing with older people, there's geriatric syndromes. So there is an increase in demands of services, especially in health services in low and middle income countries. So the best approach, and this are also recommended by the WHO, is having a very successful preventive strategies, especially in the primary healthcare level. So when you talk about managing an older person, you have to mention about the healthy aging. So it's according to the health definition of WHO. It's not merely absence of disease, but it's about the well-being of a person. And this is not only to do with the physical well-being, but the mental and social well-being. That's the definition of health. So healthy aging, according to WHO, is the process of developing and maintaining a function ability. So functionability is about the quality of life, to be able to meet basic needs of a person, to have them to continue learning and growing and making decisions, move independently, maintain relationship, and the important part, not only for them, but to the country, is to have a contribution, increase in productivity. And this depends on the intrinsic capacity and also the extrinsic capacity. Intrinsic is what we deal internally, and I'm going to talk about that more in my later slides. But extrinsic capacity is basically their surrounding, their environment, their support network. So it's a combination of intrinsic and extrinsic capacity. So if you want to have a criteria to have a universal healthcare for all the adults through a primary healthcare level, you should provide firstly accessibility, quality healthcare, which is include health promotion, prevention, and early detection of a disease, and it should be coordinated. And it's not only a one-off treatment, it's a long-term care, and this costs money. Well, we're dealing with treatment, rehabilitation, and also palliative care, which is a high prevalence in an older population. And for that reason, we cannot work as primary care doctors. We cannot work alone in silos. We have to work with in a multidisciplinary team, in multi-providers. So you have to integrate. And the thing with older person, you have to have the treatment tailored to the person's needs. It needs to be individualized. It's not that one treatment, that can fit for all. Okay, so this is what we call person-centered care, where the main aim is to have focus on the person's needs and goals. And you have to be integrated in the clinic care and also have support from the government and also the other health system. So we are used to have the conventional part of prevention, which is the primary prevention, the secondary prevention, and the tertiary prevention. We're all used to that concept. I apologize, that's very small print. But nowadays, we are moving towards a framework where we are dealing more on the functional ability of a person, rather than just focusing on the medical conditions. And this functional ability of a person to make them more productive and to have a better quality of life, it also depends on this intrinsic capacity. Yeah? So the prevention not only prevent the disease base, it's not disease based, but it's also to prevent changes that affect function. Okay, so at an early stage. And this is what been promoted by the WHO through the ICOPE approach. And what is ICOPE? It's an integrated care for older person or older people, ICOPE, yeah? So this is a global standard preventive care in older adults. Yeah? So it's ensure delivery of an integrated healthcare that will enable an older person to improve and maintain their physical and mental capacity. And this is by through promoting and maintaining their intrinsic capacity. And this intrinsic capacity is, has 6 domains, which is locomotive capacity, which is their movement, mobility, psychological capacity, which is to do with mental health, cognitive capacity, things like having a good capacity, cognitive capacity like prevent dementia, hearing and visual capacity to get them functioning. And you can see that all these domains actually relate to each other. For example, if you have problems hearing, it may affect your mobility and it may also affect your cognitive impairment. Like people who have dementia have problems, you know, if they having hearing problems, they're more likely to have cognitive impairment. And this can only be achieved by comprehensive assessment, having a personalized care plans, and a delivery of coordinated service intervention. Then again, it stresses that you need to work together, not only by the primary care doctors, but in a multidisciplinary team involving even the dental care, even the allied health, for the psychologists, the physiotherapists, and others. So, I think it missed something there. So basically, there's a diagram missing on the left side, but it's okay. This is what I just say that these things is actually achievable, and in Malaysia, we have tried to apply this concept in certain certain districts, and it's actually have some positive results, and it actually improve the frailty index of the people who have that intervention. And this also have even the policy needs to be changed, and our health white paper for Malaysia, it's actually a reform plan for Malaysia. It includes having an aging population as something that needs to be looked into and needs to be addressed. So what are the challenges? Okay, I got 2 minutes, I'll just run through very quickly. The main thing is that the primary care have its limitations. I know looking after older persons is not easy. Our primary care, even though we have numbers, but you see that the waiting time is high, and you know, if you have like consultation with older person, it takes so much time to look into all these morbidity comorbidities and overcrowding. So the infrastructure is not there, and even our workforce are not really trained to look after. We had a survey done, and the awareness, even not only for the public on dementia, is low, but also among the healthcare givers. So that's quite daunting and quite frightening, especially when having an older population, age population just around the corner. Okay. So the strategies, what are the strategies? Firstly, we need to create awareness. Okay, we need to train the primary care workforce. So we make do, this is the bottom-up strategies. So we make do of what we have, especially with the low and middle income countries. We need to train our doctors, the primary care doctors, how to manage the older person effectively. and through this person-centered care. We also can use the role of caregivers, encourage, empower them, and this can be done through social prescribing, getting them, the providers, the family members, to be one of the healthcare providers. So we get them to be, we empower them to also help us to deliver care. And has to linkage with the community supports program and local councils, integrated aging population to the national. I think this has been discussed. Okay, so the conclusion, as the world rapidly ages, proactive and collaborative health strategies must be in place to meet the growing needs for all the adults, especially in the lower middle income countries where there's very less resources. Primary healthcare must lead the effort to achieve UHC, particularly managing complexity, because primary healthcare, especially the primary care doctors, we are supposed to be trained in how to look after complex multimorbidities patients. And health promotion and preventive care must be central to support healthy aging, as what we have discussed. So the primary care workforce must be empowered, trained to support to deliver comprehensive person-centered engagement for the aging population. For that, I thank you.
Okay, thank you. Big applause for Dr. Fairuz Ali. So now we have all 5 speakers here. So now it's time to invite questions and comments from the audience. Please, the first 3 audience who wants to say yes. 1, 2. Okay. Yep. If someone can help with that.
Thank you. Assalamualaikum. Good afternoon. I'm Husni from Malaysia. I'm a family physician. I think I must congratulate each and every one of the speakers here because it's excellent. I've learned many things from each of you. But I would like to ask the first speaker, I just want to ask one particular question because I'm one of those who don't jump into AI immediately. I still try to use my normal brain function if possible. You were saying in your conclusion that AI does not, a certain section of AI reviews literature which are not recommended in that sense. Am I right? May I know which particular AI were using, or were you using a few particular, is that a general statement to say that if you are taking 3 or 4 AI applications, you come to the same thing? Or is it just one particular one that you'll be using? Thank you.
Thank you for the question. So what we did, so I divided up my class into groups of students, and every group would use a specific tool. So some would use Elicit, some would use, well, one of the students is sitting behind you, so he can tell you which, so and some of them used the paid version, and others would use the free version. And they would also check different days, because sometimes an AI model is different on one day from the other. So we compared all these different kind of approaches. Sometimes the free version was better than the paid version.
So it's like a systemic review of AIs in that sense you're doing. Thank you.
Thank you.
Thank you. For the next question, please.
Okay. Okay, thank you for the time. Maybe this answer for Prof. Tipawan. Okay. Before, in the past, I have the research in the community as the K population, specific in transgender community, who have the role in HIV/AIDS prevention program at Yogyakarta through of NGO. Based on your experience, Prof. Tipawan, how we would to do as stakeholder or decision maker to inject with that NGO for enhance the sustainable healthcare quality? Thank you for the answer.
So thank you very much for your question. So that for stakeholder identification, we need to see about the context of the countries. Even we say about the transgender, right? About the context of the Indonesia, Malaysia, or Thailand, the transgender may be different context, and acceptability of transgender may not exactly the same. And in each country, they're related to the transgender. They also have the association. They will have the group of the people that working related to this group of the people. So that is why the first, I would suggest you to look at the country context about the transgender, whether that how many organization or they have the group of the people works with them. That identify that first, because in different one in Thailand may have the difference, right? So, and after that, you need to find out the one who know more about the stakeholder will be the target population. So if we know that kind of the people, they will helping you to identify who will be the stakeholder. Because sometimes they will have group of the people working closely with this group of the people. You will get more, and then you will get the whole perspective of the stakeholder that work with them. Okay, thank you.
Prof. Tipawan and Dr. Martin for the answers. So we invite more, yeah, please, Ibu Dia.
Thank you. I'm interested in how we use evidence to make decisions or policy, because sometimes we have to compete with conflict of interest. So we have evidence in one side, and we also have other interests in the other side, and also power. So sometimes we already deliver the evidence, but how can we assure that this evidence could be using as an input for making a decisions? That's the first question. And the second question is for the last speakers on the healthy aging. What is, in your opinion, because we have a better quality of life, so that we can live longer happily. So some countries, they add the pension age, like 1 year or 2 years more. So what's, in your opinion, the challenge of this policy? Thank you.
Okay, thank you, Budia. So your first question is for Prof.
For all.
Oh, for all.
Yeah.
Okay, who's gonna start? Okay.
So because we understand that we are the academians, right? And then we produce the evidence. That is why the certainty of evidence is come from the research that we identify, and is more than the certainty of evidence because they have the multiple components that we need to consider. That is why we can look at the holistic approach and see that for some intervention they may have much more, that not only about the evidence, but we need to think about the other, and then based on that criteria we can weight each other, and then the one who led is stakeholders, and also the one who would like to implement that intervention. So the first one, we need to consider the stakeholder who weight for all criteria, whether that is possible to implement it or not. Yeah. And then we let for the policy makers to answer more.
Okay, maybe Dr. Koi, yeah.
I give you an example. When I was the WHO representative in Namibia, the head of WHO office in Namibia, Namibia passed the law for banning smoking. But the Minister of Health is supposed to develop what should be in the cigarette packet and this and that. Everything WHO did, but the minister is not signing that. Because Minister of Finance said, if you ban smoking, we will not have any tourists and we will lose money. And the money you are getting from the cigarette, it's a lot. So now if I would have told the minister, this is the evidence, he doesn't have time. So I said, Minister, can I invite you for lunch? So we went together to a lunch. I said to the minister, how long you are going to be a minister? Do you think the next time you'll be the minister? I'm not very sure, Monir. I said, what people will remember you if you are not minister? So he was really, I said, look, Minister, if you sign these things, right, people will remember this is the minister who has signed. So I said, so what can I do? I said, okay, tomorrow I'll bring all the television people, all the media people. So me and the minister sitting together, all the television are focusing them, he's signing. Next day in the newspaper, minister has done. So it depends. Evidence, that's why I teach politics of health, learning the language of politician, how your evidence can be a win-win situation, right? Right, so.
I think that answers the question.
Anything to add, Dr. Fairuz or Martin Koch, about the first question? Do you have anything to add? Okay. Okay, if no anything to add, Dr. Fairuz, the second question about the pension age.
Oh, the pension age. I think Malaysia is also going out towards that to increase the pension age to, I think, 65, at the moment for 58. So I think it's a quick and easy way and a shortcut to get, you know, it's understandable if you have a larger proportion of your population to be in the older person categories. And you know that they are not taxpayer, so they receive more than what they contribute to the country. The easy way for the country is just to increase their working life, and so they can contribute more. But the thing is, it's not easy because sometimes their function is limited. They cannot function as what they can previously, and this also can affect their productivity in terms of whether they can contribute working together with the other aged person. But I think through policies in terms of whether to get them to be more healthy, more function, like if, for example, for Malaysia, our age policy for elderly, it's very outdated. I think the last review was in 2011. So, and you can see that WHO has already progressed. Even Indonesia has also accepted the concept of healthy aging in terms of improving function, improving the intrinsic capabilities. And this should be the first, what do you call it, steps. Getting them to be more healthy, having a better quality of life, having functional abilities, and then when they are more healthier and more capable, then you can actually increase rather than just straight away increase their, the pension age. So this is just a shortcut for the country, but I don't think it's sustainable, and I don't think it's something that may get that better benefit that they need to.
Okay, thank you, Dr. Fairuz. We still have 3 minutes. Does anyone want to ask question or give comments? Yes, please.
Thanks for all professors give insightful talks. I'm Susie from Department of Epidemiology, Prince of Songkran University. So building on all professors' topics just now, I asked DeepSeek about a case. An elderly person in Southeast Asia lives alone with oral health issues and have other health comorbidities without health insurance and face high heat and air pollution. How can health systems help? So the AI's key suggestions were community health workers need to do the home visits, integrated care, affordable payment options from the NGO partnerships, and pollution adaptation support. So my question is, from all professors' perspective, what further can health systems do? Thank you.
I'm happy to take that one, because I think it's very interesting, and I think it also links back to your talk and even to your talk. So in my country, in the Netherlands, dental care is not covered. by our regular health insurance, which is a big, big problem. And I was working with an NGO, and what they did was they would arrange dentists who would provide free dental care to some undocumented migrants. And so they found these volunteer dentists, and also my girlfriend at the time was working with this organization. They would identify these undocumented migrants who have major, major dental problems. A lot of pain, some of them was even smelling awful, and they didn't want to go outside, didn't want to talk and interact, right? So they were very happy to finally go to a dentist. And they were so happy that they prepared very well. So they shaved, they make sure their hair was nicely done, they would borrow a nice suit where they could, borrow, because for them it was a big thing to go to these dentists, finally get their problem solved. And these dentists, they said, okay, I'm going to do, 1 or 2 teeth for free, but, I cannot do their entire everything for them. And they were expecting somebody looking poor, and somebody looking dirty, and somebody being very grateful. And, but what they got is somebody in a suit, looking very fancy, wearing aftershave, being all ready for this great treatment, finally get all their teeth done. But the free treatment was often only 1 or 2 teeth. So instead of a grateful, vulnerable, poor-looking person, they got somebody who was upset because they did only 1 or 2 teeth and not their entire thing. And they were like, what is this? We want to help these people who are, but it's completely opposite. And I think this is where communication becomes a key issue. And how do you deal with communities? And also, it really shows the huge dental problems that even exist in high-income countries where you do not properly cover this. So I think there's a lot to unpack, and even in these little things. And I don't think AI can help us with these. So thank you very much.
Okay, thank you, Dr. Martin. Anyone want to add to that? Okay, and thank you, Dr. Martin, for that answer. I think this concludes our question. Oh, okay. You can raise a question.
I don't know what is your experience from you and your group. AI will give you answer the way you ask the question, the formulate the question, the background you give. If your background and question is wrong, you'll get a wrong answer. What is your experience on that?
I think I need to be modest in my answer there, because we haven't explored different ways explicitly to formulate the question. That's something because we wanted to ask exactly the same question as we did for the systematic review. We did give some instruction on what could be used and what could not be used. But I think there's a whole lot of work to do there, whereby I think AI, even for teaching patients, for teaching students, for teaching staff, I think there's a lot of great opportunities that we can use, but we're still at the beginning of learning how to do it properly and how to make sure, because it's a great tool, but it's also a very slippery slope that you're on. So I think will be joint learning.
Okay, thank you. So you can discuss more outside of the session, of course, and with other participants here who wants to ask more questions. We still have 1 more days, and you can ask them during the coffee break session or our presentation. Okay, a big applause for our 5 speakers. So let me briefly conclude. So we back to the first problem, that after the pandemic, we still have 3 big problems here. We have the issues of rising costs and the aging population, so higher burden of disease, and also persistent inequities that you and Prof. Tuti raised. So, Prof. Moniro already mentioned about that we have like maybe triple burden of disease, not only communicable, non-communicable, new emerging disease, and also climate change, and again AMR. So we have a lot of that. And then Dr. Fairuz mentioned regarding the aging population, it's not only medical aspects that we need to take care about, but also the functional ability. So what about the frailty and everything? And how can we make sure that we give comprehensive care? The first one, we can care about the cost. We can give a lot, a more comprehensive care if we have enough cost. And then that's where Dr. Martin says that we can cut the cost if we select the medicine appropriately or succinctly. And then the second one, how can we optimize the cost and optimize our health system, is to provide the good primary health care, not only involving facility-based, maybe home-based, like Professor Monirul mentioned. And we can involve more community, maybe family members, maybe community health workers, to provide a various care for non-communicable disease. And how to engage community more. So, and Prof. Tipawan has explained, we can use the framework of the evidence, integrated evidence, to make community more engaged and willing to serve, to provide in our health system, to make the health system even more resilient. Okay, so that concludes our plenary session today. After this, we still have closing session. Thank you from me, thank you for everyone. Assalamualaikum warahmatullahi wabarakatuh.
Please give a big applause to Dr. Lika. Thank you so very much as moderator and also all speakers. We would like to invite all speakers and moderator, please stand to the center of the stage as a token of appreciation session. And we would like to invite the head of the committee of the 19th Postgraduate Forum to come forward to deliver the tokens. Dr. Lutfan, please. Please, all speakers and moderators stand to the center of the stage. Ladies and gentlemen, the tokens of appreciation or souvenirs are now being presented to our speakers. Dr. Martin Kok, Assistant Professor Erasmus University Rotterdam and VU Amsterdam. Professor Quasi Monirul Islam, Prince of Songkla University. And then Professor Dr. Tutiningsih Mohdam, Dean Faculty of Dentistry of University Kebangsaan Malaysia. Professor Tipawan Liap Suetrakul, Director WHO Collaborating Center, Prince of Songkla University, and Associate Professor Dr. Mohfairuz Ali, and also the moderator Dr. Lika. Please, Dr. Lutfan, have great photos with all speakers and moderator. Okay, say cheese together. 3, 2, 1, cheese. Ladies and gentlemen, please give a big applause to all speakers and moderator. Thank you so very much once again. We thanks to all speakers and moderator. And we kindly invite all of you to back to your seats. Thank you so very much. Ladies and gentlemen, what a truly productive and informative event today has been. With the completion of our plenary session 2, we now officially come to the end of the day 1 of the 19th Postgraduate Forum. On behalf of the host and the organizing committee, we would like to once again express our deepest appreciation for your participation and continued support. As a kind reminder, day 2 of the Postgraduate Forum will begin tomorrow morning at 8 a.m. sharp. And please attention to Synergy Hub program information on screen. We remind you once again that our next day will be started at 8 a.m. sharp. And please make sure everybody can come or arrive on time, as we have another exciting day of sessions and collaboration ahead. Thank you once again, good evening, and see you tomorrow.